her fibrinogen PT-PTT had been stable.
Yeah, normal.
Yeah. Um, and the white blood cell count was how much before the steroids?
Like 11 to 19. It was a big time. First
Big
job.
time.
We can repeat it.
Yeah, yeah.
He
So,
doesn't have any focal, signs of infection or fondal tenderness or things like that.
and no
Does
FTR.
complain of these contractions off and on that make her uncomfortable. So we've tried all kinds of things, Tylenol, gabapentin, et cetera, for pain control. Then she feels better and she's amenable to go home, but she's herself, currently worried, kind of caught between a rock and a hard place of going back and
Yeah.
forth from home.
And the weight for the baby is appropriate.
Yeah, AGA baby.
Mm-hmm. Okay. And the fluid had been fine, like even recently with the second admission, Eileen?
We didn't do an AFI, but yes, just
Oh, yeah.
eyeballing, yeah,
Objectively, yeah.
objectively.
Yeah, make sure you scan the placenta, even though she came a second time, scan again the placenta, check the fluid. Yeah, it's a tough case. My working diagnosis would be abruption for her. Her LFTs and creatinine had been okay.
Yes.
Yeah, with the clots and everything, like, and no cervical dilation, like, you know, um, yeah. And so now the active issue is like, what are we gonna do with this white blood cell count? So, okay, we'll see how, and the baby looked active all the time.
Yes, yeah.
Okay.
It's interesting because her contraction pattern looks kind of like an abruption where it's like the low volume frequent contractions. And that's been pretty much consistent this entire time. And that with the dark red blood that she keeps on seeing, like that also makes me concerned
Yeah.
that for an abruption.
And
But
we've been seeing like the blood too, like on her
Yeah.
pads. And
they've been like all just dark red. Nothing that we ever saw on speculum exam was ever bright red. Yeah.
Remember to request differentials. That will help you if it's more neutrophils, points to bacteria.
Yeah, absolutely. We forget about that many times. Thank you, Amanda, for reminding.
Chances of doing an anemia, infection, maybe some cold. Any source of infection aside from pregnancy?
No, she's always been afebrile. She had a negative urine culture or no, urinalysis. I think her culture is still pending. No like other systemic complaints.
Yeah, we cannot discharge her now. I think we all agree, correct?
Yeah, that was going to be my next question. Again, she was just readmitted. We just learned about this half an hour ago that she came back. Yeah, we can certainly watch her even over the weekend. At some point.
Yeah.
I feel bad that we had to remit her twice. That never looks good.
Yeah.
Back and forth. So we could just tell her you're here at least till Monday, something like that. I'm here over the weekend. We just really keep an eye on her and then see where it goes.
Yeah. And Eileen, has the fetal weight been done less than 3 weeks ago or just recently this week?
We didn't do growth class admission. She only had the anatomy, so yeah, it would be a good idea to do growth. But I think an amnio to rule out chorion will be the best course of action. Okay. And also, if there is an abruption, sometimes the amniotic fluid is bloody, brown discharge, brown color. That will tell you about abruption. Though abruption, you could continue pregnancy, but infection definitely will be a reason to deliver.
Okay.
Yeah.
Yeah, we can definitely do a growth at her last.
I believe we need the steroids last admission.
Yeah. Her yesterday was her last she was just here, so we gave her a second dose yesterday.
Have her over the weekend. Yeah, she got steroids 9/23. Oh, just yesterday.
Yeah. When we saw her again. Okay. We'll do that. Our next patient is also a new admission from yesterday, Amber McDaniels. She's a 32-year-old G3P2003 at 20 and 4, which is a history of a gastric laparoscopic sleeve gastrectomy, and chronic hypertension on Procardia 90. She presented yesterday with concerns for black tarry stools and melena. And when she was evaluated, had a hemoglobin of 9.6. Previously, I think back in July, it had been 12, if I'm not mistaken. And so she was kept overnight for a GI consult, who's going to see her today. They'll likely do an EGD sometime later today. I think that's Michaela Lino. She is a 35-year-old G1P0, 15 and 2. She presented yesterday with B-Bible PPROM. She reported a gush of fluid yesterday morning, came into the ED, and on speculum exam, there was no pooling. However, on ultrasound, there was anhydramnios. So the story is pretty consistent. Also very kind of distressed over this diagnosis. I think she had been counseled on her options and was recommended for termination, and was leaning towards a D&E, but wanted another ultrasound today by us, just to confirm that still is anhydramnios, and also just to check on the kidneys to make sure if there's no other etiology of anhydramnios. But she had a normal NT scan just a couple weeks ago. And the story sounds pretty consistent for
Were you able to see kidneys? Were you able to see kidneys?
We haven't done the ultrasound yet.
Oh.
Yeah.
Fine.
We'll see. I don't know if they saw it on the 12-week ultrasound, but
For you to know, our hospital don't do autopsies below 16. So if you wonder about this baby had kidneys, you better go to the operating room and find them yourself, because they're not going to do autopsies. I've been frustrated with sending specimens and they don't process. When the autopsies are free, they don't charge for that procedure, so they're keen to do them.
And the last patient, Christina Snee, is 38-year-old now, post-op day 1 from a gravid hysterectomy for placenta accreta. Spectrum, everything went well. EVO was 200, complicated. She's onc primary. I'm just gonna see her social hello, and then
Did you participate? Were you able to scrub?
I scrubbed. There were 2 gynonc attendings. There's going to be three.
So in the report.
Yeah. So Dr. Kelly and Dr. Go, the new gynonc.
Oh, there's another guy.
She just started. So they were the ones, but and then Dr. Rosenblum came in towards the end too. So there was a lot of people in the room, but it was very cool to see the actual and I'm glad that there was no bladder invasion.
I think it was worse than we thought. When they lift the bladder, it was completely like nothing in between the bladder and the uterus, was just placenta.
Yes, exactly.
That's what we saw in the ultrasound. It looked terrible.
Yeah,
The MRI showed like a window.
Yes.
But I think in real life it's worse than the MRI.
Yes. Yeah.
The
I sent the
ultrasound
picture,
is
but
yes.
that was only partial. I was only partially viewing the placenta, so there was more further down.
That was a really good.
Yeah. The ultrasound continues being the best technique to diagnose accreta. It's just for a few millimeters away, so ultrasound is always best.
Yeah.
They like the MRI because they're used to it. It's more like tradition than actual who's going to give me the best diagnostic. So ultrasound is always best. And remember that when you do transvaginal ultrasound, keep the bladder full so you can see the interface between the bladder, you can see the lines. Sometimes I can see mucosa, fascia, muscularis, and then uterus, and then you don't see it. It's like by layers. Like the ultrasound is very good information. So, and be sure that you are sometimes present to know if it's go into the room and watch the sonographer going, sweeping, and make a lot of color Dopplers with full bladder. So you are able to see the interface and tell the surgeon, be aware of this. I talked with Dr. Kelly Monday. Be aware of this placenta, it's more to the right, it's more to the left, careful with the cervix. Please do, did they do total or supracervical?
No, they did total. They were able to get all the way
Yeah,
down.
I told you, like, not a good idea to do supracervical, even with the uterine artery embolization, the supracervical. I think there was some infiltration into the cervix. The MRI said no, but I'm sure that the anterior lead was taken.
Yeah, that would have been, I think it would have been really morbid if she went to term. Like, my other question was, like, so you see it now, it's not yet invading the bladder. As if she decided to go, like, full term, would you see eventual bladder invasion, or is it more like it'll kind of tend to?
I don't think they progress as
Okay.
the pregnancy goes along. I think it's the same, and it's as bad if you don't do uterine artery embolization and just go for the hysterectomy at 20 weeks versus 35 weeks is equally bad. The difference is you can do a uterine artery embolization in pre-viable, so it's dry, it's more comfortable hysterectomy, and Dr. Kelly told me that the last 2 obstetrical hysterectomies have been dry with like 500 cc CBL versus the viable baby when we cannot do any interventions before delivery.
Interestingly, purely curiosity, we did doptones after the UA focus, and there were heart tones.
Oh,
That's amazing.
yeah. So baby didn't pass during the procedure of the radiology procedure.
There must have been enough collateral.
So that tells you that there are still a lot of collaterals.
Amazing.
What happened with that cervical/C-section scar?
Oh, she did great.
Yeah.
I was impressed. Actually, I have some videos I can show you when presenting her. How can I?
It was her, and then there was also our
Will we
lady.
talk about?
So I forgot to review this, but there is a paper by Dr. Timur Trish that said they put the cook balloon, one inside of the uterine cavity and one inside, one in the cervix. So basically tamponating and sandwiching the cervical ectopic. So she was reading in the office about this paper, and she decided out of the blue to do this procedure at 5 p.m. And I was like, "What are you doing?" I'm the Kavita. So she's reading and she texted in the secure chat. Actually, change of plans. No interventional radiology. I'm going to put this double balloon tonight. And I was like, I'm a backup person. What are you doing? And she's like, no, this works. And I just read Dr. Timur Trish papers, so something that we should review. And this works. And I'm going to do it. And I was like, okay, let me help you with this. The ultrasound is not good. It's this laptop computer, but I took a video when she was advancing. So I was scanning for her. She advanced the first balloon into the endometrial cavity, pulled a little bit, and then inflated. It caused a lot of pain. She was in Laudil something. And
She's on PCA.
PCA pump overnight. That's inflating the balloon into the endometrial cavity alone. That was very painful. And I was like, okay, nothing happens overnight, no bleeding. The beta before the procedure of 58,000. In the morning after, before the DNE was 2,500, meaning that she detached the sac with the balloon. But somehow I hope the balloon controlled the bleeding. I don't know, but she didn't bleed overnight. And the next day, Sonia's grabbed, because we didn't have residents, and I was scanning. And I also made some videos. That it was a standard DNC.
She removed the balloon. There was
Removed the
minimal
balloon.
bleeding.
I think we didn't even, I think she went 50,
What did she inflate the balloon?
20.
It was 40 and 40.
I don't remember the Bakri balloon, not that much.
It's a double balloon cook,
It's a
right?
big balloon.
Yeah.
The same, she took one of the balloons from LND.
Yeah.
She took one of the balloons from LND.
Yeah.
And I was like, okay, and she's like, don't worry, I'll come overnight if she bleeds. Don't worry, I will not call you. The first thing I woke up in the morning is looking, no, nothing happens, no bleeding overnight. The procedure was like in any other knee. She removed the balloon. What did she do first?
Sutures in.
Lidocaine dressing in the cervix, so I think that also helps with the bleeding. And then
The
some
DNC.
Stay sutures.
Stay suture, vasopressin, stay
the
suture.
sutures. What is the reasoning for the sutures?
Um,
Just holding.
Just getting the vessels at 3 and 9 o'clock.
But did she tie them?
And we left them.
And we left.
So vasopressin, the stay sutures, then the DNE. And then after we watched her replace a Foley balloon, I think 30 cc's, we kept that in for a few hours. We deflated it maybe 4 hours after.
No
No
methotrexate.
bleeding, and then removed it, and she did fine.
No KCL either.
Like minimal
Just
bleeding.
less procedures, very successful, minimal bleeding. I think she didn't even get 100 cc's.
No, wow. And it was dark blood. There was no like bright red active.
So with the double balloon, the gestational sac detached, and so much that the beta went half down, and no bleeding overnight. They were like, wow, because as you remember, cervical ectopics is the ones that we fear the most in the obstetric gynecological world. So no minimal bleeding. And then we discharged her next day. I went to see her. She was fine. No bleeding, brown discharge. No issue. She went home. It's very stable, and I have not heard from any other complications after that. So it was very effective. We need to review this paper. Timor Trish, cervical ectopic double balloon, some journal club already. Review, but it was great. I was like, what are you doing at 5 p.m.?
You said it, even if it was a C-section scar topic, she would have done the same thing.
Yeah.
Yeah.
We also published.
So it worked very well, and I'm like, but she was like all secure. This is what am I going to do? I'm like, okay, I'm going to stand for you and help you and be at your bedside. And I was like, with my fingers crossed.
This was done at the bedside?
She did it in the emergency room in a very uncomfortable gynecological bed, and I was like, oh, at least like in a better bed. No, she did it there.
What happened to the kyst?
Kenya.
Yes.
So Kenya, as you know, she got the trachelectomy in Abington, 8 units blood. She bled like what, 3 liters, something in Abington. She came, urology placed bilateral PCNs, but they still kept the suprapubic catheter. They had 2 JPs. The one was removed as far as I can tell, and she was discharged Monday with the PCNs, the suprapubic balloon. I think 1 JP. I'm not sure about a poly balloon. I mean, she had cables everywhere. Her wound was closed with staples. I didn't like one area. She had MRSA wound infection before, so she
was messaging you.
yeah, and so she got a lot of antibiotics. And Dr. Kelly said, no, they won't look good. I don't see the need to open unpacking. For the cell phone to the patient. So call me directly if you have issues, and she probably is coming next week. And during that admission, we're just working on nutrition and recovery. But she was recovering. The worst acrita that we ever had, heavy bleeding, readmission, new surgical procedure. We never had that. We had one before that had one of the peduncles, so I think the ovarian artery or the round ligament got loose and bled 2-3 liters. Who was there? I don't remember who we did this acrita with. I remember Simone was running. Simone Reeves. So that was, and Dr. Scott, Richard Scott, came back from home to open her up again, and there was a lot of blood, and he just tied few knots, and the lady was an Indonesian lady.
No, but that was,
I don't remember who.
Kanika Vom.
Yes,
that was-
no, that's different. That's a different patient. This one, the fellow was Anna, and Anna came from home to help me with the second laparotomy. That you said level 3, level 1 surgery, and it still took like 1 hour to get into the operating room. And these people were so slow opening the instruments, and we couldn't get cell saver. The cell saver came late. Nothing happens in 5 minutes. It's very impressive.
This might be a question for more for urology, but she had it sounds like a cystotomy during the first case.
She had
Repair.
multiple cystotomies. I
Oh,
think
why
it's
did
close
she-
to the trigon.
Oh, that's why, okay.
So if you destroy the trigon,
Right.
then the ureter implantation has a problem
Okay.
and doesn't heal well. And I hear that she may need a reimplantation later.
Wow.
She may need another surgery. If this, so the idea to do the bilateral PCS was to allow enough resting time into the bladder, so the bladder is like non-functional,
Okay.
to allow healing.
Yeah.
So who knows how long they're going to leave this in there.
But the ureters themselves were not injured.
No, but the trigon may be, and I think if there is a bladder injury, so depend of the distance from the trigon, from the ureter implantation, so 1-2 centimeters something, so if you are in the dome, no problem,
Exactly,
stitching,
right.
they recover in a
So it was
week.
near the track.
But these ones were multiple cystotomies close to the trigon, so it needs more time, and the sphincters may be disrupted.
Isn't there like a difference if they did a total hysterectomy rather than like a supracervical? Like,
Well, that's my lessons learned, I think, don't do supracervicals in Acritas.
Agree, 150%.
I told her, but she thought it was going to be, this, Dr. Kelly told me the surgery was being perfect, but the time she clamped the supracervical area,
That's what the problem, that's where the problem is about it. So
Yeah.
you have to take that cervix out. You know, it's the hardest part, but
they were gonna do supracervical again, and I was like, oh no, like, but
please don't.
oh no, but then the other attending was like, we can do this.
please try to
Yeah,
do
yeah.
a total hysterectomy because I'm concerned
Push.
with the cervix.
Yeah,
I'm concerned there is a piece of placenta in the anterior aspect of the cervix.
yeah, yeah.
But this one allow better dissection. I think they got in the other case because the blood, it was basically the placenta went through and through the bladder because she had hematuria. Never seen that either. So bladder rupture, everybody's upset because now she had multiple cystotomies. I think the case started getting an anxiety, so she probably wanted to finish sooner, and then it just started bleeding. And then the bleeding got out of control. Couldn't see anything. She was bleeding. So the decision was pack, resuscitate, come back later. And the uterine artery embolization or whatever left is there worked well. She went home. She was perfectly fine for 4 weeks. So I don't know. I think I need to ask Dr. Gonzalez about her opinions on this situation. I actually don't know. She knows the patient came back. My theory is could be a couple of things. The gel foam dissolves from 4 to 6 weeks. So it could be that the gel foam was dissolving and the rehabilitation. And the cervical stem has vaginal branches, and those branches can also go anastomosis with the rectal artery coming from the mesenteric artery. So this is something that could recanalize. And second, it could be time her menstrual period. So hormones stimulated the cervix. Some women with supracervical hysterectomy had some bleeding from the endocervix. So it could be just it was hormonal stimulation from her ovary. But it was pretty dramatic. They told me she was sitting in the dining table and suddenly started pouring out. What other
I have a
case?
patient who needs to be admitted to Center City from Jersey.
Oh, you
So-
said, I was
Stephanie.
waiting for you. Did she come already?
Yeah, she's here.
Stephanie? How's
Yeah,
she?
so just a reminder, guys, she's the patient I briefly talked about last week. She's 40 years old. She's a prime. I initially saw her when she was 9 weeks pregnant, and at that time, she only had a diagnosis of type 2 diabetes, obesity with a BMI of 33, and a prior myomectomy with a recommendation for a primary C-section. At 14 weeks of pregnancy, she developed chronic hypertension and required rapid uptitration of medication. She's currently on 3 agents, nifedipine, Lipitor, and Hydral. And she also had no proteinuria initially and now has over a gram of proteinuria on her last 24-hour urine protein. In addition to that, she's been growth restricted since 19 weeks. And so the whole picture put together sounded a lot like superimposed preeclampsia, which I talked to her about. I recommended termination of pregnancy given that she was pre-viable, and she declined and wanted to continue expectant management and pregnancy prolongation. So she's here today. She's 22 and 6. Her baby's EFW is 366 grams, which is less than the first percentile. She has previously had absent end diastolic flow. Today she has periods of reversed end diastolic flow. She continues to desire an attempt at pregnancy prolongation and expectant management. And I do not think that we are the appropriate location in Jersey to do that. I talked to her about admission to Center City, which she had already been prepared for, potentially betamethasone and ICN consultation, blood pressures, labs. I already warned her that I think it's very unlikely that she's going to get more than a week or two at most of additional latency given the changes in the umbilical cord, and that it may actually be even less than a few days. She is asymptomatic today. I have not checked her blood pressure because I didn't want to check it after I told her all these scary things, but I will check it before she leaves, obviously, to come downtown. She's also getting a fetal echo right now for her type 2 diabetes, and so I'm letting that finish. With respect to her type 2 diabetes, she's on an insulin pump that's been primarily managed by endocrine. We'll have to get endocrine on board. She had admission for thyroiditis in August in Center City, required a course of steroids. Her steroids are now done. She has mildly suppressed TSH, mildly elevated T3 and T4. She just saw endo last week, and they said they didn't want to treat it, continue to monitor. They're expecting that she's going to become hypothyroid on the other side of her, thyroiditis. And then there's a question of a cholestasis of pregnancy diagnosis on a workup for transaminitis. The transaminitis is no longer present. She has no symptoms. I think that's the least of our worries. And then she, again, has a prior myomectomy and is for primary C-section when she is for delivery.
What's her name?
Okay,
I'll give you some.
No.
That was perfect. Give me your MRN.
Yeah, I'll send you a secure chat.
You.
But don't be on secure chat during teaching.
Thank
Just,
you,
I'll
Whitney.
send it. I'll send it. I'll tell her to come through triage.
Dr. Benner, she got steroids for her thyroiditis, correct? Not
Yeah,
for
but she
Correct. She has not gotten fetal dose steroids. She got a steroid course for her thyroiditis of PO steroids.
Oh, okay.
Because at that time she was like 18 or 17 weeks pregnant. Okay, sorry.
Thank you so much.
Thank you. All right. I'll try to continue to listen.
Sorry, out of curiosity, what was your A1C pre-pregnancy?
Actually not bad. 6.3.
Oh.
Yeah.
Oh.
I think she got in trouble with the thyroiditis.
Me too. I think the thyroiditis tipped. Though
And that
she was
can be
hypertensive
like-
before the diagnosis of thyroiditis, though, hard to know if her TFTs were trending up and we didn't know it yet. But yeah, I think the thyroiditis, whether or not it's the chicken or the egg here, is questionable, but it's definitely related in some way.
Her T3 is 5.0 and T4 is 1.8. It's actually better than last time. She was
Yeah, it's improving.
6.0 and 2.8.
Yeah.
So very bad thyroiditis.
Okay. Thanks, guys.
She actually was sent to us thinking that she was in a thyroid storm. Remember, I don't remember who was with lovely couple. She's 40 years old, first baby.
Was it IVF?
Yeah, I think so.
I have one
Go ahead.
outpatient,
Yeah.
but I wanted to survey the team to see if there's anything else we can do for this patient. So Diaz, Lady Garcia Diaz, she is a 25-year-old G4P0211 at 12 and 5 today. She was seen for an MFM consult. Her history of preterm delivery, G1 at 32 weeks. She also had a SAB at 16 weeks. It seems like she ruptured, so periviable pre-prom. And then her most recent pregnancy, she had fetal demise, secondary to a suspected intrauterine stroke. This was in 2014. Her workup for the fetal stroke showed negative APLS testing, negative KB, negative DIC panel, negative infectious panel. She had a normal chromosomal microarray decline genome sequencing, and there was no autopsy. She was offered NAPE testing but declined because she did not want the FOB to be like involved in the process. This is a different FOB. Yesterday she had her consult and NT scan. The discussion that we've had was kind of doing an early anatomy at 16 weeks, and then she's going to get serial cervical length screening starting 16 weeks because of her history of preterm birth. But we're trying to figure out, is there anything else that we can offer her in the setting of having this history of a fetal stroke with so far a negative workup? Or if this plan is like enough for her care and we kind of just monitor.
What comes to mind, it's NATE testing. Have you discussed that? Or?
Yes, we did, but then I look if we could do any testing on the mother only, and they need both parents. Because I think the test they put maternal blood and paternal blood in the petri dish, and they need to react to each other, and the father is not available.
Different father this pregnant.
Yeah, different father, which does not guarantee. It's not like thalassemia genetics that we have couples in the past. This is not a guarantee that it's not going to happen. And so she's aware, but she didn't want to contact the previous FOB.
You know, Alexa helps us a lot when we have to do this NATE testing. So in a future case, you can always, use her, and she knows a lot of the details. Because it's not just as easy as doing, for example, antiplatelet antibodies. There are many different kinds, and as Amanda's saying, they need to be cross-reacted. Usually, the first time it's NATE, it doesn't happen this early, like at 16 weeks. It would happen more in the third trimester, the second trimester. So that's also another reassuring for the history. Do we have the records for that terminal stroke? Like, where did it happen?
Yeah, it was.
We diagnosed it with rupture.
Okay.
She came at 25 weeks with decreased fetal movements. She was placed in the monitor.
You got 25 weeks.
25, yeah, I think it was 25. And she was flatline. The residents did a sort of a BPP, and the baby was not moving, zero movements. So they call us for.
It was an intracranial.
Yes, we saw it. Like Rusha was coming back from home to do her scan. I was on my way back from New Jersey, so she called me to have a second look. And we scanned together, and there was a very hyperechoic area in one of the choroids. Like 50% of the hemisphere was white. And the baby was not moving, zero BPP.
And the baby died.
So we discussed we cannot save the baby even if we do C-section right now. And even if we keep you in continuous monitoring, we cannot save the baby. So she agreed to stay overnight to observe. And in the morning, baby had demised. And she got a DNA. So we couldn't get a brain for pathology. And she got antiphospholipid syndrome that was negative.
Yeah, negative.
But there is, I was wondering if there is anything else.
I mean, that is suspicious, honestly, for.
And it will be a huge difference in plan if she has NATEs because of the IVIG.
Yeah.
But she does not want to contact them.
We have pictures from
I think this is the last pregnancy.
the last pregnancy of what it.
What was the plan then? To do an 8 workup?
Yes, but she declined. She has been declining since that delivery. She does not want to.
I mean, if she doesn't want it, that's not the first story.
Yeah.
But that would be what if there was an FOP available, given this history, definitely.
We don't do
the NATE.
we don't do cervical lengths in triplets.
You're talking about different case?
Asking for.
Yeah. Let's finish this case. Anything else about this case? I don't.
We are just gonna share the pictures.
Yeah. Share the pictures.
Yeah, basically, I don't remember if I met her, but maybe I did, but I
You saw
think
Dr. El-Guatley.
what?
You saw her for a consult.
And she declined genetics, correct, if I recall?
She declined genome and she declined NATE testing. It was something you recommended.
Yeah, so there are many single gene etiologies that can associate it with fetal intracranial bleed. So actually, this is a nice idea for us for another fetal therapy, basically fetal stroke. you know, not that-
The one we did at that side.
July
Yeah.
of 2024.
Yeah. Yeah, she's obese and it was very difficult to see, but see that hyper,
Yeah, right there.
that the choroid was all white. And the most impressive thing, this baby didn't move at all.
So there, the teaching point is also there are different causes, of intrauterine, field stroke, so to speak, or intraventricular hemorrhage and stuff. But Nate, it's the one that should be at the top of your differential, and it should be able to, then it could be an anomaly of this baby leading to the stroke, other issues that are less common. Every like red blood cells anomalies, etc. But Nate will be the one who, in this case, we can't have nothing to it. Interesting case, very interesting case.
Will be any room for empirical therapy? I mean, the therapy is quite expensive and high risk for allergies and reactions.
So the only thing, you could, I suppose, study if she has antibodies herself now and see his antigens. You could do that even if it's a different FOP. It's uncommon. But you could do that. I would involve Alexa and re-evaluate it with the patient and see if the lab would do it with a different FOP.
Okay, yeah.
If you're looking for pups, this is certainly
I
possible.
remember the couple that had Nate, I think the first baby you delivered, remember, like 20 years ago, and then had like pups in every pregnancy.
So Colleen Thompson is probably the most famous patient we've ever had. And she has 7 kids now. She had the first baby, Michael. Alexa remembers this better than anybody else. Then I think she had a baby who had an intracranial bleed, was worked up, had Nate, very Christian Orthodox mom. And so eventually we followed her for this homozygous Nate. I think she had the most common, PLA1 antibodies, and he was homozygous for PLA1 antigens. So, one pregnancy, I think we did 11 pubs for Nate, transfused platelets to the baby. One of the, so we'll like follow 5 or 6 pregnancies like this, and one point, and every time was more difficult. One time we actually had a bradycardia complication from a pubs at 26, 27 weeks. The baby was born. At some point, almost declared dead by the neonatologist. Low platelets, low hemoglobin, told the dad. Eventually, the baby's now survived and did well. After that, she had twins, which were both affected. So we were doing pubs of 2 babies. No, we did not. Eventually, by then, the data was more and more than, we used to do platelet transfusion for Nate all the time, like every week sometimes by literature and by our experience. But then IVIG was shown to be very, very preventative of stroke in people with Nate. Then steroids on top of the IVIG were shown to be beneficial. And eventually, Colleen was on high-dose steroids the whole pregnancy, IVIG every week. And with the twins, actually, like we were going to do 20-some pub, we decided, you know what, you're going to have a maximum dose of steroids, maximum dose of IVIG. And she did well, actually. The twins did okay, but very complex pregnancies. Okay. Any outpatient? Did we done ultrasounds?
Ultrasounds, really the big one was the patient that was admitted on Monday.
Oh,
Very wrong. Yeah.
Okay, but you have also a cystic fibroma on it.
I can show that.
I think it's an interesting case.
Yeah, I can show that picture. She delivered, so
Mary was the one who was always subjectively wanted the food look low, but it was always objectively.
Guy twin with the cords are so comfortable there.
Had discordance, but it wasn't like, it was notable, but it wasn't like super significant. There was no restriction. The Doppler varied like super. It's normal. Sometimes it was all over the place. She'd been a CHOP, she had a consult. And we kept calling.
it was a contraindication.
Yeah.
So that's.
And they were basically like
Laser.
laser. She wasn't a candidate for anything additional at CHOP unless she wanted selective cord occlusion. She did, so.
We reviewed a paper on like the proximal cord insertions, and they found to be more highly prevalent in selective FGR type 3 babies, and that they're also at higher risk of demise. So it was like 12%, 6%. And the thought is that they also have large A anastomoses, and that the dynamic shifts and like instability can cause like demise of one fetus. And yeah.
Very much followed, unfortunately, this article and the most recent data. It's something we used not to think. We would measure the distance between the cords, but now there are more and more data that's really an ominous sign, and they don't do too well. It's so unfortunate. She had one single embryo transfer, and now the split. The cords were next to each other. The Dopplers were abnormal. She hit all the complications. Very sad situation.
She underwent, I'm just pulling up those other images, but she underwent induction. It sounds like the delivery itself had been uncomplicated, but at the time of her, after the delivery subsequently had acne, required several tonics. They did several bimanual exams where there was retained placenta. She lost 3 liters of blood. They went back for a DNC. And she ultimately, they placed a JADA, and after some time they were able to, remove JADA, disconnect it. She did require 4 units of packed blood cells, 1 of FB. And then of course subsequently developed arthritis. Stayed for about 24 hours, was discharged sometime yesterday. It sounds like the only thing they noted in terms of placenta was that the cords were proximal, but there was no other documentation of what.
Remember that if you go to pathology, they just have a different system with canal access. They take pictures of everything. So if you want to look at the specimen, you just go to pathology department and they will show you the picture.
Did we close the loop with Dr. Kayla?
Hello?
Did we all like Kayla? We've been calling about her. She did.
I don't know if she was updated.
I don't think she was.
Yeah. Okay, I have her number.
Okay. It would be good to update them on the outcome. They were
I
doing
think I updated
better.
her to Federica, but double check since you first were in touch with her. Good check.
As I said, twin troublemakers.
Yeah, that's one big time.
Some of them go really south. When I still remember the lady who I consulted, and the father said, "I am Dr. Bloom for giving such a grim prognosis," and she developed twin-to-twin transfusion, HELLP syndrome, fetal demise at 22. Everything. She got everything. Severe preeclampsia. It was a disaster.
Just logging on to my Zoom. Yesterday, we had seen a patient for an NT ultrasound, 43-year-old prime, spontaneously pregnant. Fortunately, also a friend of Megan, our sonographer. And we did her NT ultrasound, and I'll show you the findings in a second. For the passcode.
Do you need, I can share.
No, I'm just getting on, I have it up, I just have to get onto the passcodes. I can't, can never remember it.
I guess that when we're done with the patients, you could probably present your presentation on what we're done here with patients.
I'm trying to, let me put it back into the single pics.
Somebody wants to comment?
So this is our first picture that we see.
We're looking at a sagittal view of the crown rump. And you can see there's a large fluid-filled space concerning first.
Yeah. Transverse view of the fetal brain. There's some more interesting pictures of this. So look at the arms, right? Pretty short.
Looks weird too.
Looks a little bit flattened in the profile. Hard to say if it's like angle.
With a wrong angle, that definitely looks flat. But.
The arms.
So what are we seeing in this view? In this arm?
Let's see, that was it. No,
Is it demonstrating like, is it clenched or?
it looks like rigid, it looks short to me.
Shortened, yes.
Yeah.
So what part is short?
I think it's like.
So the middle one.
Yeah.
So
The humerus you
there's
can
a
see, and then the
medial.
next thing you see is like.
And the hand, they're normally open at this time of pregnancy. This hand is clenched,
Can
or
we go back to it?
maybe the other possibility is that the phalanges are shorter.
See humerus.
Ah.
That might be, but you.
See that either they're flexed.
Yeah.
There is something wrong with this hand.
It's like a little paper over cup. Yeah.
I can't really tell exactly what that is. Legs are also shortened here.
Yeah.
Long bones we're able to see, but we can see that the more proximal part of both the limbs are shortened. And also the angulation is really interesting.
Looks like arthrogryph.
I was like, normally at this time of pregnancy, the legs look like a frog when jumping,
Yeah.
and they're extended, so you see two femurs. And usually this is how you see the legs of the 11-weeker. And that's not what we're seeing there. There is a deviation, the angle, I think the knee.
Medial deviation of the media.
Yeah, very interesting case, Amanda, dear. Is she on my schedule?
So Dr. El-Kawatli, rather, I'm going to actually, so I was with Dr. Bender. This was the last case of the day, of course. And we spoke to the patient. She was obviously in a state of shock. And is someone who Megan was like, I don't know if she's going to terminate, but I think the patient will likely terminate. So really the conversation was like about what are the next steps. I have a scheduled phone call with her tonight at 7:30.
Okay.
And then I will let everyone know based on the results of that conversation, what she desires. We did have her scheduled for genetic counseling. We also drew NIPT yesterday. She has, we also reached out to the family planning team too to set up a conversation on options counseling. And then essentially we're just gonna go from there.
Yeah.
Also the face.
Yeah, but she
the
was-
face is still in all the views that were taken, all the videos. The face is flat.
Yeah.
And I don't know if there is a little bit of frontal bossing, but definitely the profile is not normal. I
Yeah.
think this was the best profile and it still was.
Kavisha, sorry, she's not set up for genetic counseling. That
Oh,
was,
she isn't? Okay.
no, she wasn't really like,
Oh, because right, because
Just wasn't
Friday I was
really
going
ready
to
to do-
confirm with her
yeah,
tonight.
she wasn't ready to do any, yeah, I don't think she could take the next step yet, other than getting her blood drawn for NIPT.
Okay. Alexa, I talked to Claire about her, so we're gonna overbook tomorrow if she wants, okay?
Yeah, I'll reach out to her. Like I said, I'll talk to her tonight at 7:30. And then I will text you, Dr. Alquatli,
Yeah,
after I speak to her, and then also text Alexa and Dr. Bender so that everybody's aware.
yeah.
Um,
Hey,
after-
this is Steph. Sorry. Looks like she communicated with Sydney today, like an hour ago. So I would reach out to maybe the
Oh,
family planning nurse.
she wanted to have a family planning conversation regardless for options counseling. So I had messaged Sydney. I don't know if she said she wanted to proceed with Danny.
Okay, so Kavisha, just, you call her, dear, and let us know her decisions, okay, dear?
Absolutely.
But this profile is very impressive. This is how your probable achondroplagic babies are gonna look at 12 weeks early. Look at the frontal busing that Dr. Oman have mentioned. There's like flat maxillofacial features, yeah. The bones appear short, nothing that appears fractures, it seems. So if of course, we'll always start with the microarray on patients like that, but then after that, probably, short of having, an exome or genome covered for her, it's going to be like a skeletal dysplasia gene panel, basically, which has like with the positive ultrasound, a positive predictive value of almost 80%. So that's the gene panel for skeletal dysplasia has the highest yield, basically. So this is a very impressive case. Thank you for sharing it with us,
And
Kavisha.
for her, excluding genome, you would do microarray, Noonan, and skeletal dysplasia panels.
I think in her case, I would go from microarray to skeletal dysplasia because of the extremities and because of the frontal bossing. But yes, if we had the money, we can just do the genome basically. But yeah, so far we can always, stand up and, fight and negotiate for our patients, which many times we have been successful, but I want the approval for the patient also, So,
Huda, if you can talk with Claire then and figure out a time for tomorrow, then maybe message Kavisha and I, and Kavisha could talk to her about that. And if she wants it, I can always add it in this evening into the schedule.
okay,
It's
great.
particularly if it's for the morning or something.
Oh, of course. Thank you so much, Alexa.
Sure. Thanks, Huda.
What time is the possible pups being scanned today?
1:30. We tried to get her to come early, but unfortunately she had some obligations, so.
Yeah, that's good.
Yeah.
Great.
What is next in the agenda?
That-
Presentation?
I think Rupshas will start at 10:30, so I think if you wanna do your slides, yeah, let's do that, so we'll move ahead through the agenda.
Yes, so basically, just to give an introduction, last week I attended the Phytology conference, and for the fellows, never stop learning, always attend meetings. You always get surprised with how much you know. Our field is always moving very, very fast, and I thought, we haven't talked about this topic. That may become the norm when in like 5 years, or something where, it's gonna be like, okay, you have to do it. So with that said, so Sajid was asking for a topic, and I told her, you know what, let's just do a very focused lecture on just like the fetus surgery for gastroschisis, because we may have to be referring our patients like we did for the vasa previa, which is an amazing evolving field we are in. Thank you, Sajid.
Thank you so much, Dr. Alpilarli, for suggesting this topic. This is kind of a follow-up also to Sonia's lecture from last week. So I'm going to be mainly discussing about the current ongoing trials about fetal surgery for gastroschisis. Kind of the outline we'll be discussing about briefly of the overview from last week. Then we'll be discussing what has been currently done, including amnio exchange, early delivery outcome studies, then the animal study, which was done in 2023, and followed by the ongoing fetal surgery trial. So as we discussed last time, we know that this is a congenital para-umbilical abdominal wall defect with herniation of intestinal structures from the abdomen. The prevalence is about 4.9 per 10,000 pregnancies. It is basically two types. The simple gastroschisis is otherwise has a healthy bowel with just an inflammatory peel over the bowel surface. And versus complex is kind of more serious, which is characterized by bowel complications, dilatation, bowel dilatation, anything more than intra-abdominal bowel diameter more than 10 millimeters is considered bowel dilatation. Then other complications might also be there, including like bowel volvulus, atresia, stenosis, necrosis, and perforation. So currently the standard is the postnatal repair, which is like primary reduction and repair, which is preferred. But sometimes if it is not possible, then kind of a plastic silo can be used till the time the defect is large enough for the bowel to go inside to achieve the primary repair. In cases of simple gastroschisis, the postnatal outcome is really good and the prognosis is good. But in cases of complex gastroschisis, this is still associated with significant mortality, up to 11% in the US and up to 17% in European centers. So that is kind of the rationale behind doing the fetal surgery trials for complex gastroschisis. I think we already went it over last week, a little bit about amnio exchange. It is believed that, like if the amniotic fluid around the baby is exchanged, it would be exposed to less toxins. So Luton et al. Performed a randomized control trial across 8 referral centers, including 64 patients, in which they started amnio exchange around 30 weeks and repeated every 2 weeks until delivery. But they did not find any significant differences in the outcomes between the two groups. Then about regarding the early delivery in fetal gastroschisis, there have been 2 randomized control trials. One of them was a study in 2005. I haven't included here. That has it included around 46 patients, 23 in each arm. They did not find any significant differences between the early delivery group and the late delivery group. And one of the recent studies, which was a randomized controlled trial done at Texas Children's Hospital, evaluating the potential elective preterm delivery at 34 weeks versus the expectant management. They were only able to enroll 25 patients, and the trial had to be stopped at the first planned interim analysis. Due to concerns for patient safety, they found that there was no benefit between the two groups, the early preterm delivery and the standard routine care. And they also kind of had few cases of early delivery with gastroschisis. They were complicated by late onset sepsis. So currently, there's also an ongoing trial on gastroschisis outcomes of delivery, the GOOD study, which is currently enrolling patients. The main objective is to all right, maybe The objective is to investigate the hypothesis that delivery at 35th week in stable patient is superior to the observation and expected management with the current delivery like around 38 weeks. So this is also a randomized prospective multi-institutional trial across the NAFNet. That's fine. Okay. Yeah. I'm sorry. I'm seeing the participants over here, so I cannot read it from here. So this was enrolled. This is a study across the NAFNet affiliated institutes. They are enrolling patients prior to 35 weeks and randomizing them at around 35 weeks to kind of the first arm with delivery at 35 weeks, and the second is observation with delivery at 38 weeks. The primary outcome is stillbirth, neonatal death prior to discharge, respiratory morbidity, and the need for parenteral nutrition at 30 days. The study is still ongoing. We don't have the results from there. Then this was a really interesting paper from the UOG journal about complex gastrous cases. They kind of went over why it is a new indication for fetal surgeries. They came with the idea that this might be favorable according to the International Fetal Medicine and Surgery Society criteria, which is like for any fetal intervention, it has to have established natural history and accurate prenatal diagnosis, which kind of we already discussed. In case of complex gastrous cases, would we be calling it if the intra-abdominal bowel diameter is more than 10 millimeters, and the absence of fully effective prenatal treatment due to prolonged need for neonatal intensive care in the complex cases. And then there have been few experimental studies and of the fetoscopic repair and the maternal and fetal safety of fetoscopy in expert fetal centers. So these are kind of the IFMSS criteria for any fetal condition, like to meet criteria. If it meets criteria for these different factors, then they are kind of considered as an indication for fetal surgery. Then this was a paper in SMFM in 2023, or presentation about safety and efficacy of open fetal repair of complex gastrous cases and the fetal lamb model. So their study was done on fetal lambs, and the standardized complex gastrous cases was induced at 75 days of gestation. At 90 days, the defect was repaired using a stepwise fetal procedure, which involved reducing the bowel into abdominal cavity and subsequent suturing of the abdominal wall. And they compared the outcomes between the unrepaired and normal lambs at term, which was 143 days. They found that about 71%, 5 out of 7 of the repaired complex gastrous cases survived to term compared to the 45%, 5 out of 11 unrepaired lambs. And at term, they did not find, there was no microscopic evidence of stenosis, atresia, necrosis, perforation, or volvulus in the repaired lambs, whereas 100% of the non-repaired lambs exhibited one of these findings. So their conclusion was that prenatal intervention might improve bowel safety, bowel anatomy, and physiology, and they suggested that further studies are needed to further investigate the feasibility and safety of fetoscopic repair before a definitive implementation. So this is the current ongoing trial, which is going. Children's Hospital is the main place where it is happening. This is fetal repair of complex gastrous cases, a safety and feasibility trial. Their objective is to evaluate the safety and feasibility of fetal repair of complex gastrous cases via fetoscopic surgical approach by assessing the maternal, fetal, neonatal, and infant outcomes in a cohort of 10 patients. So the study design is they propose to offer minimally invasive in utero repair technique as an alternative to the traditional standard postnatal surgical repair. And the idea behind the surgery is during surgery, they're planning to do the same way as we do for the spina bifida repairs. The mother's uterus is opened using a stranded laparotomy approach that is currently used in open fetal surgeries, and the fetus will do spina bifida repair through the exteriorized uterus, and then they plan to repair the defect, followed by closing the uterus. All the participants will be closely followed with ultrasound, and the patients who deliver at Texas Children's Hospital will be included. Coming on to their inclusion criteria, pregnant women more than 18 years of age who are able to give the consent for the participation in the study are included. Singleton pregnancies, then sonographic evidence of complex gastroschisis, which we already discussed, the intra-abdominal bowel dilatation of more than 8 to 10 mm at 20 to 24 weeks. Then absence of significant associated anomalies diagnosed on prenatal ultrasound or MRI. Gestational age at the time of procedure will be between 20 to 25 weeks. Further inclusion criteria continued, absence of chromosomal and clinically significant abnormalities, that is the normal karyotype and or normal chromosomal microarray by invasive testing. The patients who have refused the invasive testing will not be included in the study. And then also the family has been appropriately counseled and they have considered and declined the option of termination of pregnancy at less than 24 weeks. The psychosocial criteria like sufficient social support, ability to understand the requirements of the study, and parental or guardian permission or informed consent for the follow-up of the child after birth. Their exclusion criteria include any significant fetal anomaly which is unrelated or related to gastroschisis. If there's evidence of bowel perforation, which is can be seen on ultrasound by intra-abdominal bowel calcification. Then if there's an increased risk for preterm labor, including short cervical length, history of incompetent cervix with or without cerclage, and previous preterm birth in a singleton pregnancy. Then if there are placental abnormalities like suspicion of previa, abruption, or accreta at the time of enrollment, if the pre-pregnancy BMI is more than 40, and if they have in journal contraindications to surgery, including previous hysterectomy, like whether from a classical cesarean or from a uterine anomaly, or a major myomectomy resection in the active uterine segment. Further exclusion criteria include any technical limitations for fetoscopic surgery like extensive uterine fibroids, fetal membrane separations, or uterine anomalies, maternal fetal RH aluminization, KEL sensitization, or neonatal alloimmune thrombocytopenia affecting the current pregnancy, maternal HIV, hepatitis B, hepatitis C positive because of increased risk of transmission to the fetus during the maternal fetal surgery, or any maternal medical condition which is a known contraindication to surgery or general anesthesia. Low amniotic fluid if deemed due to fetal anomaly or poor placental perfusion or membrane rupture. The last set of exclusion criteria, patient doesn't have a support person or severe depression as diagnosed on the APDS score, or patients who have enrolled or have been enrolled in other intervention study that affects the mother or the fetus. Their outcome is primary outcome is successful repair of complex gastroschisis, and the secondary outcomes include preterm birth, IUFT, total time on total parenteral nutrition, time to initiation of enteral feeds, necrotizing enterocolitis, short bowel syndrome, length of stay and other complications of prematurity, and need for additional surgery for gastroschisis, and the neurodevelopmental and survival outcomes at 12 months. That was all. Thank you so much for your attention.
It's nice to see, more level 1 evidence, getting into, fetal therapy interventions. This stuff has been discussed for a long for many years, and now for more therapy centers, and it's nice to explore some of the stuff we've had questions all along, to repair in utero, when to deliver, et cetera, et cetera. So nice summary, and hopefully we'll have some interesting data soon.
Yeah.
Yeah.
We started in 2022. They plan to get the results by 2027. So
Okay.
they planned.
So I think the lead author, Dr. Kiswani from University of Texas Children's and MFM, and he's enrolling like patients even international, and they pay for everything. So I just want to add a sad truth, which is that, many of patients born with gastroschisis outside first world country like Europe, United States, 80% mortality, which is very, very sad. And he presented this data. And this is actually what inspired him. Is this something we can change, to have more babies alive with gastroschisis, basically, So basically, he's championing what Dr. Bergella is championing for preterm birth, but he's doing the same for gastroschisis. So it's very inspiring to see people, who are so much passionate about changing what we do. So he has videos, everywhere. So also, okay, great. Thank you.
Thank you. That they do like a laparoscopy, and then they do like a stop. The uterus is outside of the body. And I don't know, it's just very cool.
There is so much advanced, like the open neural tube defects. They were doing open, taking the baby out, doing surgery, and now they're doing that by laparoscopy.
Yeah.
So I'm sure eventually these cases can be done by laparoscopy as well. So it's less morbid for mother. Just endoscopy, 5mm trocar, maybe a second trocar, but the advances is when I watched that video for the open neural tube defect by laparoscopy, I was like, wow.
Like laparoscopy, even for the mother, like
inflating
with CO2.
No,
Okay.
So they go into the uterus and they
Got it. Okay.
Sometimes the cases need maternal laparoscopy if the entry, let's say, where is the placenta? If you had an anterior placenta, how do you place the trocar into the uterus? So I remember one of the twin transfusion cases who had a difficult placenta required a laparoscopy doctor. So they did maternal laparoscopy and they sort of rotate the uterus and to avoid bowel injury. And then the fetoscopy was entered laterally and through the posterior wall of the uterus while the laparoscopist was holding the uterus in a little bit of rotation. It was like 5 people, a lot of maneuvering, and they managed to do the placental ablation through the posterior wall of the uterus. I mean, when you had a problem, you have to figure out how to solve it, and people come with different ideas, and that's what I did. And I was watching, I was like, wow. That was when I was in residency in Texas with Dr. Moniz. Let's say here, when you call Dr. Tiffy, he rotates the uterus somehow, and another team is doing some other thing. Some patients are extremely challenging.
Okay, you want to do your thing?
Yeah, sure. So let me log on to the Zoom because we're going to continue our SPSS.
Maybe 85.
No, that's that conversation. So. I can like disconnect from the audio or something to make sure this doesn't mess up, or it's fine.
Yeah, yes, we do completely.
Yeah, my volume's off. Okay. So we will continue our SPSS lecture, and just to review, last time we had done, we talked about the basics of SPSS, about organizing your how to define your variables, how you think about categorical in general, what are categorical versus continuous variables, and what are potential confounders. So just as a reminder, last time we looked at categorical variables and doing a regression analysis for categorical variables, and we talked about a few different ways to do that. Hold on, I realized I'm not sharing the screen here. Things. You guys see okay? Keep this like a Zoom call. Okay. So just as a reminder for looking at something categorical, you would go to analyze, regression. Oh, I'm in the wrong data set here. Sorry. Easier to do from computer at home. Okay, here we go. So for looking at categorical variables, you would do analyze, regression, binary logistic, and then your outcome of interest would be your dependent variable. So in this case, we're looking at preterm birth, which is yes or no. And then in your covariates, the first block of covariates, you want to include whatever you're trying to adjust for. So anything that you feel like you need to adjust for. So if this, like, we'll adjust for, gestational age at enrollment, EMI, whatever. And then in general, we talked about the difference between enter, which looks at everything individually, versus looking at something backward selection, which is more important when you're trying to look at a number of different predictors and see what's most relevant. And then your next block will be your actual factor of interest. So in this case, we'll look at progesterone assignment. And then you have to define your categorical variables. You need to say, what is your comparator going to be, whether the first in the category, so if you have, or the last in the category, which it basically tells you which way your risk ratio is going to come out to. And so that's how so it's important you define that correctly so you're drawing the correct conclusions. And so in this case, to make it, I actually don't remember how I categorized it. So we'll just leave it at first and I'll show you what it looks like. So this is the output. So first you want to look at your case processing. Missing cases tells you if anything was excluded. Cases would be excluded if the data was missing for any of the variables that you input as your like dependent variables, your factors of interest. So in this case, nothing was excluded, so that's good. You always want to make sure that you don't have a large number of cases excluded, and now the population that you thought you were analyzing is actually a different population. This is showing you how things are coded. So vaginal progesterone is coded as 0, and 17-OHPC is coded as 1. And so we're comparing, in this case, we had selected our comparator was going to be first category. So that means we're comparing 17-OHPC to vaginal progesterone. And then so that's what you can see here, where it says parameter coding. Vaginal progesterone is what's the reference, and then 17-OHPC is what we're getting the odds ratio compared to vaginal progesterone. And then you go down to your I realized I forgot my confidence intervals. So let's do this again, and I'll add the confidence intervals in there. In options, you have to put this, and you can define your confidence interval. I always do 95%, but if you're doing something else, you put it there. So now let's go to our output. So block 1, it's entering the variables that we entered in block 1. We looked at gestational age of enrollment, BMI. You can see the significance, that's your p-value, is all greater than 0.05. None of that was significant. The EXP, that's the odds ratio. Saying how this affects the odds of preterm birth less than 37 weeks. And again, you can see this confidence interval is crossing 1, which goes along with the fact that the p-value is greater than 0.05. And then we're going to look at our outcome of interest. So see, this says progesterone assignment 1. So again, it doesn't tell you what the variable name is. That's why you need to pay attention to how you coded it. So again, how we coded it, it was looking at 17 OHPC versus vaginal progesterone. P-value is 0.29, so it's not significant. The odds ratio is 1.3, so if what's significant, that would mean there's a greater risk, 30% greater odds of preterm birth with 17P versus vaginal progesterone. And then this is your confidence interval. Again, it's crossing 1, so that was not significant. So that is looking at a binary outcome. Now I want to talk about how you look at a continuous outcome. And so few things to think about when you're looking at a continuous outcome. The first is you need to decide if it's normal or not normal. And I know we had talked a little bit about this at our last discussion. And just to oh, did we say? Okay, so you want to look at if it's normal or not normal, and there's a few different ways of doing that. So let's just look at our we'll just look at gestational age at delivery, for example. So there's a few different things that you can look at. Sorry, just find the variable. So the first is you can just take a, look at what, this is just how you look at sort of just the descriptive. So if you just want to get an idea of sort of how does this look? You go to descriptives, frequencies, and statistics. And I'm looking at both mean and standard deviation as well as median and quartiles. And it's going to look at the skewness as well. And then you can also make a histogram and show the normal curve. And so these are all different ways of kind of displaying your continuous data. So let's see what it looks like. Again, we included all 188 here. So here we have our mean and standard deviation. We have our median and the quartiles. So you can get your interquartile range there. This isn't comparing anything. Again, this is just looking at it. And you can see, so just looking at this, do you think this is normally distributed? No. Yeah, it's a little skewed. So I don't know how to make this far go away. I don't know.
Can you move it away?
Hide here.
Wait, which?
Okay, there we go.
Oh, that's, yeah, so.
Even if it's skewed, is it normal distribution?
No, so if it's skewed to one way or another, then it's not going to be distributed. And then you can also do over here. And oh, you know what, I wanted to show you the other thing, and then let's do just as a comparison. So we looked at gestational age of delivery, let's also look at gestational age of enrollment and see how that looks. So in this case, you can see this is normally distributed. So you can see the difference there. So this data set is a randomized trial. And so you can see there was a normal distribution and sort of when people were enrolled. And as is commonly the case, gestational age of delivery is not usually normally distributed. And so I just like to highlight this because when you're thinking about how you're going to do your comparison of a continuous variable, the type of test you do will depend on if it's normally distributed or not. And being aware that common things that we look at, like birth weight and gestational age of delivery as continuous outcomes, are usually not normally distributed. So that's one thing. So if your data is not normally distributed, there's a few different ways that you can address that. So the first thing is, if you're comparing means, you should have normally distributed data. You can do, so again, we're looking at how to compare continuous variables. You can go to compare means. And here we'll do an independent sample t-test. And we'll do our grouping variable. It's going to be progesterone assignment, 0 and 1. So now we'll find out. And let's look at our two variables. Let's do gestational age of enrollment and gestational age of delivery. Go to your options. Again, you can pick what you want your confidence interval to be. And then we'll do okay. And oh wait, I did the wrong. Okay, hold on. I did the wrong group definitions. Let's try this again. Again, compare means, independent sample t-test. This is actually 1 and 2, not 0 and 1. Okay, so this is what you get when you get your t-test. So it gives you the mean and standard deviation for each variable that you're looking at. So, gestational age of enrollment and gestational age of delivery. And then I want you to look at first thing here. So the Levene's test of equality of variances. So this is one of the things that you can do to account for sort of how skewed your data is if you have a difference in variance between your two sets, which is often what would lead to difference in having normally or not normally distributed data. And so you can see over here, your gestational age of enrollment, that test for equality of variance, the significance is 0.6, meaning that you can assume equal variance. And so the mean difference that you would use and the p-value, et cetera, would be assuming equal variance. If over here, the equal variance is 0.06. So it's technically also, you can assume equal variance, but you can see the difference there, which is reflected in the difference in how the data was distributed. But same thing. So that's what the Levene's test of equality of variance is. And based on that, you would pick sort of whether your mean difference that you're reporting is assuming equal variance or not assuming equal variance. In this case, because you can see that the variance was equal, that the outcomes are the same. You might have, when you do have unequal variance, if data is quite skewed in one group compared to another, you will see small differences in these two values. It's not going to be a dramatically different result. So what the information that you get here, so again, this is the mean difference and then the 95% confidence interval for that mean difference. And you can do that for as many, as many independent variables that you want. Now that is comparing means. Now, if you have data that's not normally distributed, or you don't know if it's normally distributed or not, you can always do what's called a non-parametric test. And in general, for data that's not normally distributed, you should be doing a non-parametric test. And so I'm going to show you how to do that. Go to customize analysis. Let's go to our fields. So again, and the test fields is your continuous outcome that you're looking at. So we will look at gestational age of delivery. I need to organize these variables better. Here we go, gestational age of delivery. And then our group comparison is going to be progesterone assignment. And then you can go to setting. And so I like to customize my test so I can see a few different things. I'm going to do Mann-Whitney U. That's basically the most common test that is done for comparing non-parametric data. Excuse me. And then I like to do both comparison of medians as well, and that gives you a median difference. And then estimate confidence intervals, and then we will do one. And the only other thing I'll add here is that Wallace one-way ANOVA test that allows you to compare across. So, right now my variable is 2 items, right? Either got one of 2 different types of progesterone. Maybe you're comparing something that is like across 3 categories. For example, you're looking at comparison of gestational age at delivery across like 3 BMI categories or 4 BMI categories. In that case, you would do the Kruskal-Wallis one-way ANOVA test, just as you would do an ANOVA for comparison of means. Right now, this variable I've selected is just a binary variable. So we're just doing the 2 sample. It's just comparing, across 2 samples. So we'll do that. And then, so over here, you can see this is telling you that that you should retain your null hypothesis, so your Mann-Whitney test is, the P is greater than 0.05 for both gestational age of delivery for the median as well as the distribution. And then if you go down, this is just a graphical representation of your data. This is your class summary, so our p-value is 0.06, and this just shows you sort of the distribution of your data. So it's just a visual representation. The other way that you can, compare continuous data is a survival curve. And so survival curve is something that you would use specifically for a time to event type of outcome. So you could look at, in this case, for example, gestational age of delivery, where you consider gestational age to be your time and delivery to be your outcome. You could look at, other things would be like latency from an intervention to your outcome, whatever your outcome of interest is. So I'm going to show you how to do a survival curve. First, we'll do a Kaplan-Meier, and then if you look at Cox regression, I'll show you a bit different. So this is Kaplan-Meier survival curve. Time I've put as gestational age of delivery. Status, that's your outcome variable of interest that you're assessing. So in this case, I'm looking at just delivered, yes or no, which everyone will have been delivered. You could, for example, do something different where you're looking at gestational age as time, but you were looking at your outcome as like early preterm birth, less than 34 weeks. And so you're interested in sort of latency to that outcome. And as long as people get to 34 weeks, you don't really care what happens after that. So there's different ways, that's what your status, will be defined by whatever that outcome of interest that you have is. Over here, factor that I'm comparing it by is progesterone assignment. You can also further stratify by different strata. So for example, I could do progesterone assignment, and then I want to further stratify by like cervical length category, for example, but we're not doing that right now. So then compare factor. Log rank is your common statistic. We don't have separate strata. So here, this is just pooled over strata, but you can also look at each strata, and we'll go into that in a second. And then we'll go to options. And then this is our output. We'll get our survival table if you want it or not. It's a long output, mean and median. I'll add quartiles in there. And then plots. You want your survival plot. That's sort of what you're used to seeing. So then, excuse me. Hit OK. Again, make sure everything that we want is included. This is the survival table, and it's basically saying at what time point someone had each case had that event, and so it's just an output of basically all your data. This is our, this is where we're getting into our outcomes. So over here, you have the reported mean and standard deviation and median as well for each group. This is the quartiles for each group. This is our log rank test. So again, so P is 0.04. That means there is a significant difference in latency or in gestational age at delivery, or latency to delivery, I guess you could say, between the two groups. And this is our survival curve. You know, as with anything, you can adjust the axes and everything to be more reflective of what you want it to show. Cumulative survival in this case is percent undelivered. So that's what that means. So what this is showing you is that at each gestational age, what percent of patients in each group remain undelivered. And so you want in this case for this outcome, you want to be on the top. You want to be a higher level, meaning across gestational ages, there is a higher proportion of patients in that group who remain undelivered. So let's, I'm just going to adjust the axis so it's easier to read. So we may make this 20 weeks to 40 weeks. So this is how you would read it. So, at the beginning, everyone's at 100. Well, this is 20 weeks. So meaning like, everyone is still pregnant at the beginning of your trial or when you're starting your time. And then as you are advancing in gestation, in each group, there's going to be people that get delivered. And overall, what our test is testing for is overall, is there a difference between survival or remaining undelivered between these two groups over time? And the P was less than 0.05, so there is, and you can see that with vaginal progesterone, you have greater survival, and that, And the way that you report that is that you would say that your log rank, with a log rank or Mantel-Cox log rank p-value of 0.046. So that's your p-value that you're reporting. So any questions about that? So far, we've just done comparison of continuous variables without any kind of adjustment, okay? Meaning that this was a randomized trial. We're assuming baseline characteristics were the same between groups, so we haven't adjusted for anything. So what happens when you do need to adjust for things? So let's go to, close this out. Let's go back to our comparison of means. So when we initially compared just simple comparison, we did a comparison of means. If you want to look at, if you want to do a comparison of a continuous outcome and adjust for differences, you're going to do a regression analysis. And in this case, instead of it being binary, which is looking at a binary outcome, we're going to do a linear regression. Here, okay. Oh, there's a little bit of a lag. Okay. You'll see that the setup for a linear regression is similar to the setup for a binary regression, and that you still are going to put your dependent variable, and in this case, we'll say our dependent variable is gestational age of delivery. And then you'll put your independent variable. So in this case, let's just, so this will be like, let's say we're adjusting for gestational age of enrollment and BMI. And then we'll put our variable of interest is progesterone. Same thing, statistics, we're gonna do 95% confidence interval. I don't usually do any of these plots. And yeah, so this is just like with a binary logistic, this is saying that if for backward selection, anything with a p a value of greater than 0.1 will be taken out of the model, and anything with P of less than 0.05 will be kept in the model. So those things, again, are all things that you can adjust. And then let's look at our output. So here, we are looking, so again, our first block was looking at gestational age of enrollment and BMI. You can see that there's no significant difference here between the two. Over here, you can see that adjusting for gestational age of enrollment and BMI, we have a significant difference in the mean gestational age of delivery. And so how do you interpret this? So this is, remember again, the way that we characterized with any kind of regression, it's saying with every sort of increase in your variable, you would have this either increase or decrease in your continuous outcome. In this case, so if we were to interpret the BMI, for example, let's just say that this was significant. It would say for as your BMI increases, this B, that's your coefficient, is negative, meaning that your gestational delivery will decrease by 0.01 weeks. And conversely, as the gestational age of enrollment increases, your gestational increases by 1 unit, so that's 1 week, your gestational age of delivery will increase by 0.02 weeks. And so what progesterone assignment means is, you have to remember which way you categorized your variables. So vaginal progesterone was 1, 17p was 2. That means as you go from vaginal progesterone to 17p, so with 17p, your gestational age of delivery is decreased by a week. And so this means that the mean difference is the equivalent to a mean difference because it's just a binary outcome. So our mean difference is minus 1.06 weeks with a 95% confidence interval of -2 to -0.04. Okay, so this is basically, so if you were reporting this would be an adjusted mean difference. You've adjusted for other variables and you're seeing this. Okay, so that is, again, that's doing a linear regression, and when you have just a binary outcome, you're reporting an adjusted mean difference. You can also do an adjusted survival curve, and that's called a Cox regression analysis. So if you go to your Cox regression, your survival curves, you go to Cox regression, you'll see a lot of these setups are the same. So time is going to be our gestational age of delivery. I can find it. There we go. Status, again, we're going to go with delivered. I'm going to say is 1. And then our covariates, we'll look at gestational age of enrollment and BMI. And then our progesterone assignment. And then, we'll define our categorical variables. Progesterone assignment, we're comparing 17p, I guess, compared to vaginal progesterone. So vaginal progesterone is our comparator. Look at our survival curve. And then here, you want to do separate lines on your survival curve for the covariate of interest, like the variable of interest that you have. So in this case, we want to look at the difference in lines between, by progesterone assignment. And what was it? Options. 95% confidence interval. Okay. And so here, you can see this is the adjusted survival curve, looking at gestational age of delivery, vaginal progesterone versus 17p. In this case, you don't have a significant difference. You can see our significance is greater than 0.05 for any, so none of these markers were related to gestational age of delivery. But so that's a Cox regression. And so it's called a hazard regression. So it's like the hazard of your outcome, or it's also called a hazard ratio. That's what you're reporting. So that's how you would do an adjusted evaluation. And here, so your hazard ratio, this is what you would report. Just like with our variable regression, you're reporting your B. That's the odds ratio or hazard ratio, sorry, 1.2, and then your 95% confidence interval. So the hazard, again, the hazard, like the risk of being delivered is 1.2, greater for 17p versus vaginal progesterone over time. Again, the confidence interval here across is 1, so that's not statistically significant, but I just want you to know how you interpret what that B means. And again, critical that you know how you defined your variables so you know which direction you're drawing your conclusion for. And then same thing, you could look at for BMI or gestational age at enrollment. So again, these numbers are small. So BMI hazard ratio is 1.00. So basically that means there was no, there's really no impact on BMI and your gestational age of delivery. Okay. And then just to show you what strata would look like if you were doing a survival curve, I'll just do our survival curve, and let's just see if we stratify by BMI, for example. So let's compare factors, and we'll say for each strata. So it is basically like doing a subgroup analysis within your subgroup of BMI. And so we'll say, okay, and I'll show you what it looks like. So here it's giving you your comparison within each BMI category. So now we're stratifying our results by BMI. And so your output will be, so for BMI that's less than 35 and BMI greater than 35, you'll get your overall comparison. So BMI less than 35, P is 0.09, BMI greater than 35, P is 0.22, and it'll give you your 2 different survival curves based on strata. So that's just how you would stratify. That's how you do a stratified analysis, which is also essentially like a subgroup analysis. And so you can both report your data overall, and that's how you'd report it within sort of specific subgroups as well. Any questions about that? I know that was like a lot of information on regressions, but that's, the basics of comparing continuous data. If we have time, we can also look at an ROC curve. Do you guys want to do that? I don't. Yeah. So what is an ROC curve for? Does anyone know? So this is go ahead. Really? No?
Oh, isn't it plotting like sensitivity or like 1 minus, I remember like.
Yeah. So it's looking at sort of the predictive ability, basically. So there's a few different so the plot is sensitivity and 1 minus specificity, and it's telling you how it's a way to sort of present data for a screening test. So if you're looking at a screening test and how well does this screening test reflect, the ability to predict an outcome. So for an ROC curve, you need a continuous variable that is your screening test result. So it has to have more than like 2 categories. It can be ordinal also, but some kind of numerical variable that's your screening test result, and your binary outcome of preterm birth, yes or no, whatever it is that you want it to be. So, for example, this is a data set of all patients with who had a short cervix and were taking vaginal progesterone. And I'm going to do a couple of things to sort of illustrate a few different statistical tests that we've been learning about, just to kind of bring things together. So first is, let's say I want to say like, okay, you know what? As we talked about this morning, there are patients with a short cervix taking vaginal progesterone who still have an early preterm birth, and maybe those are the patients who need a cerclage. So how do I identify these patients? Everyone's coming in with cervical length. I think this data set is actually was when we used 20 as the cutoff. So everyone's cervical length is like 20 or under. Which one of these on vaginal progesterone is going to end up with a preterm birth that we need to be identifying for further intervention. So first, let's do our regression analysis and see what are the baseline characteristics that are associated with having an early preterm birth. So first, let's say our outcome will be preterm birth less than 34 weeks. So spontaneous preterm birth less than 34 weeks. That's our outcome. So what variables may be related? BMI, sure. Cervical actual gestational age at diagnosis, cervical length. I wonder if this is the right cervical length variable. No, index cervical length, that's what it is. So, and then let's see what other variables might be related. Prior cervical surgery. So if you've had like a prior TNE or something, you know, or LEAP, maybe that's someone who doesn't do as well with vaginal progesterone. Seems like a good, okay. And then because I have a lot of different variables here, delivery too, I want to know, like, what are the ones that are the strongest in their relationship with spontaneous preterm birth? And so I'm actually going to do backward conditional. So I want to just include, like, excluding things that might be related to each other. For example, you might have funneling and a short cervix. So, but is it the funneling or is it the short cervix? Things like that. So I want to sort of be able to tell the difference between those two.
Is that what backward conditional?
Yeah, so it will basically go through each one. It'll say, these are weak, take them out. Let me recalculate. These are, and then, oh, I got a significant improvement in the model. Okay, let me go through these. These are weak, take this out, improvement in model. These are weak, I take this out. Oh, my model is worse. I'm going to put it back in. So it goes it kind of goes stepwise through each covariate to see, do I keep this in the model? Do I take it out from the model?
What are the other ones that are?
Oh, so enter is just looking at everything together. Forward conditional is rather than starting with everything and taking it out, you start with one, you add another, and then or not, and then you add the other one or they're not. So but backward conditional is sort of the most commonly done is you start with all of them and then start looking, winnowing away. So first we'll define our categorical variables. And then first, so it's going to be one or zero. So yes versus no. And then the rest of those are continuous. And then for options, so this is where, we'll do our confidence interval, 95%. This is the problem. This is what you're asking about a little bit, Kavisha. So probability for stepwise. So for removal, over here, it's 0.1. If you want to be more generous, you might say 0.2. So you know what I mean? So you can be sort of as strict as you want. You could say like, look, actually, even if there's like a 80% chance that it's, 20% chance that it's related, I want to keep it so that you'd increase it to 0.2. So, and things wouldn't be removed unless the P was greater than 0.2. Over here the removal is 0.1. And then entry, so the significance is 0.05. And so, and then I always, like my output to show me every step of the way too, so I can see what's happening at each point. So over here, first of all, there's 4 missing cases. That means there were 4 people with missing data, probably BMI. That's what usually ends up happening to me. And so for one thing, it's like if, for example, you want to, and we're not going to go into want to include all of your cases, you might go back and be like, oh wait, which one of these variables was I missing data on? Let me go back and get to that. But regardless, we will do this. So let's go to our beginning block and see what it looks like. So over here, let me see if I can make this bigger. Can you guys like read the numbers? Or you're looking on your computers, right? Okay, good. So over here, step 1, this is just throwing everything in. So what comes up as significant? Not BMI, gestational age of diagnosis, yes. Index cervical length, yes. Prior cervical surgery, no. Age of delivery, no. Funneling, no. And then, so it actually tells you up here sort of what was removed at each step, but we can go down and see. So, sorry, this is All right. So over here, it's telling you the significance of the change. So if you removed gestational age of delivery or index cervical length, you would have a significant change in your model, whereas BMI, cervical surgery, age of delivery, funneling, that's not changing your model. And so basically it's going through everything and dumping things that are not influence your model until you get to your final point. And so each step, one thing has been removed, and then it recalculates it. And then whatever's like the weakest link, gets removed in the next step. And you keep going until you are left with, you can see, for example, step 4, we were left with gestational age of diagnosis, index cervical length, and funneling. And I also want you to see how the p-value has changed. So the more variables you have in a regression model, the more you're like diluting the potential impact that you can detect for any given variable. And so this helps us be like, well, all these things might be related. Let me take a look at all of them. And then you're like, okay, you know what? These 5 things actually weren't. And it's diluting my ability. It's creating more noise, essentially. So having BMI, age, funneling, it's like creating more noise that's making it harder to identify what is significantly impacting my outcome. And so as you remove that noise, you will get sort of your p-value, your significance for the factors that are significant may increase. You may also find significance that in your initial model was not, because you had sort of confounding by something else. So you can see the change. So over here, like gestational age of diagnosis and index cervical length, that was significant. Like, nothing's changing dramatically, but the p-value has changed so that the significance level is greater. And then what else does it tell us? So if this is, index cervical length, it's significant, our odds ratio is lower. So what does that mean? The odds ratio is 0.85. That means as your index cervical length increases, the risk of early preterm birth decreases, right? That makes sense. And what's the other one? Gestational age of diagnosis. The odds is 0.65. So as your gestational age of diagnosis increases, the risk of preterm birth decreases. Also makes sense. We know that the earlier you're diagnosed with a short cervix, the higher the risk of an early delivery. So this is, intuitively it makes sense, right? But so that's what this is telling us. So in looking at, these 5 different factors, really what's really impacting someone's risk of early preterm birth is both gestational age of diagnosis and cervical length. So that's important, right? That means it does matter when you diagnose someone, that someone's risk of early preterm birth at 23 weeks is not the same as your risk of early preterm birth at 18 weeks or 20 weeks. And so this is saying there are 2 very important factors, and those are the 2 of them. So that's one thing. So that's like, identifying, that's for if you're doing any kind of study where you're trying to say, what are the risk factors related to this outcome? That's how you would do it, and that's how you would interpret it. What I did was I then used that to make a risk score. So I basically you would like if you have an individual patient, you do like gestational age times 0.6 plus cervical length times 0.8 equals your risk score. So that's one way to make a risk score is you use the odds ratio from your regression analysis as like the multiplier for each variable. So things that so the weighting of a variable basically depends on the degree of the odds. So something with, for example, like 0.6 times X will have a greater weight, or will pull something down more than 0.8 times X. So that's kind of how you're factoring in the strength of the effect of these variables. And so we made a risk score. So let's see how well does our risk score do in predicting early preterm birth. So in this case, we are going to do a ROC analysis. So let's go to ROC analysis. So what is the test variable? So this is going to be this risk score. And what is our state variable? So that's again our outcome. We're going to say 1 option. So so over here, you can change this if A larger test result indicates a more positive test. It basically just shows you which way your like curve is flipped on. It just changes how it looks. It doesn't change your result value. And actually, before I do that, I want to try this with, I'm going to show you this with just cervical length alone. So because we do cervical length screening, right, for preterm birth prediction and prevention. So how does cervical length predict preterm birth? So over here, for example, we would say a smaller test result indicates a more positive test, right? So the smaller your cervical length, the more likely you are to have an early preterm birth. So that's sort of what I mean when I'm talking about that. And then I want to display our ROC curve, and I also I'm going to do the coordinates. So I'm going to show you what this all looks like and the U-dot index. Okay, and so let me show you what this prints out. So this is what our ROC curve looks like. So this is reference line. That means 50-50. That means you could flip a coin and it would be as good as your test. So something that is close to this line is bad, okay? In general, when you're looking at ROC curves, what you're defining is the area under the curve. So an area under the curve of 0.5 or 50%, that would be like this line, means that it's basically as good as flipping a coin. It's not a good test, okay? So for example, you could have an area under the curve of 0.53. That's statistically significant, but it's 0.53. So it's still not a very good test, although technically it's like has significance as predictive value. So, and when just for you, like when you're interpreting outcomes, anything with like 0.9 or above, that's an excellent predictor. That's an excellent test for predicting the outcome that you're looking at. 0.8 is very good. 0.7 is good. 0.6, people usually say is moderate. So it's like, okay, it's better than nothing. And then anything in the 0.5s is really not useful. So here we have an area under the curve of 0.74. This is our significance. P is less than 0.001. And then, of course, you always want to have your 95% confidence interval. So it's the confidence interval is 0.64 to 0.84. Okay. So that is looking at index cervical length. So now let's look at the coordinates. So, let's talk about what this means. So in your axes, what this curve is showing you over here is sensitivity. Who remembers what sensitivity means?
So a test that is highly sensitive, if like it rules out the whatever you're looking at. I said that correctly. Sensitivity rules. In us now.
I don't really know what's up everything. So.
Highly specific now, so.
Yeah, if you test negative, you're sure that it's
It's essentially a screening test.
It's a good screening test because the rules will
always
always
catch up.
Used for a diagnostic
And a
test.
highly specific test makes it more likely that you have the disease if it's high.
Rules in.
Yeah, rules in, yes, yeah.
I don't know.
Test character, I guess.
Yeah, I'm not sure if I'm following that.
True positive.
Yeah, here, let me see let's Google that chart real quick, because I don't have it in a lecture for you.
False, no,
Hold on.
False
Here.
negative.
Yeah.
True positive, that's false negative.
Step 2.
I swear.
Yeah. Hold on, you guys are all saying slightly different things, which is a mix of definition and interpretation. And
It's like, given that you have a positive test, what is the likelihood you have?
No,
that's positive predictive value.
True
Positive
over
I could
true positive plus false negative.
Yeah.
Yes.
Because it's basically that first column.
Yeah,
There we go.
and then the
That's
other
it.
one goes percentage.
First
Positive predict value.
Here we go.
First
Okay, guys,
Yeah.
let's make sure we're all talking about it. So this is, I just make this bigger.
Every single test we've taken since, I think the last one.
Yeah, okay, so here, so sensitivity is the ability for you to pick up that disease state, right? And so it means of everyone who has this disease, what percent will be detected by your test? So do you want to have a high sensitivity or a low sensitivity? You want to have a high sensitivity. Now, the downside to a high sensitivity is what? Correct. So if you have a very high sensitivity, you could potentially also have a high number of false positives. It means like, great, you've caught everyone that's going to get cervical cancer, and also 500 people that got leaves who did not, were not going to get cervical cancer. So you also want to look at what your false positive and true negative numbers are. And so that is your specificity, right? And so for specificity, do you want it to be higher or lower? Right. So over here, when you're looking at this, you want your, so the specificity is going to be a lower, like the lower number. So you want your sensitivity, of course, to be high. You also want your specificity, or your 1 minus specificity, to be low. So the higher your specificity, the lower your 1 minus specificity. So you can't have, you can't have, 100% sensitivity and 100% specificity, right? That's not like possible. You're always going to have some degree of false positive and false negatives. But you want to try to have a high sensitivity if you're looking at this graph, and a low 1 minus specificity, so high specificity. So you're always, in any test that you're doing, now that we know this screening test is predictive, right? It's moderately predictive, 0.7. Where your cutoff will depend on what you are balancing as far as sensitivity and specificity goes. For example, if you have a very aggressive intervention, has a lot of risks that you would do based on a positive test result, well, then maybe you want to be more conscious of specificity because you're worried about those false positives. You don't want to be doing an expensive, next step or a dangerous next step for people that, actually predicted wrong. Versus, oh, you know what, we have a really low cost intervention, low risk intervention for this potential screen test result. Okay, great. Let's try to increase our sensitivity. And sure, maybe that, we have an extra 20 people that get this treatment, but it's a low risk treatment. So, so we're going to do it. A great example of this would be like risk score for giving people aspirin. Like, it's really shitty. Like, let's be honest. It is very broad and good sensitivity, sure. But there's a lot of people who score in who will not ultimately get preeclampsia. But aspirin is a low-cost intervention that we're trying to get everyone at risk because it's okay if some people take aspirin and they didn't really need it. So that's an example where your trade-off is the other way. If you're not sure, if you don't feel strongly one way or another, you just want to find sort of what balances both, then you would do what you would select a Udon index, which is what sort of which identifies sort of what this point is here, where you've balanced your maximizing your sensitivity and specificity. So you balance sort of the trade-off between sensitivity and specificity. That's like the peak of your area under your curve. And so that is given over here. So, and just like eyeballing it, you can see that our Udon index will be will be a cervical length cutoff that gives us a sensitivity of about 80% and a specificity of close to 80%, or 1 minus specificity of around 20%. And so here you can see this is our Udon index. So these are our cervical lengths. So this is, we're used cervical length as our screening test. And this is the sensitivity and specificity of each cutoff that you use. So of course, you know, if you use a cutoff of cervical length less than 25, that's the entire population in this cohort. Your sensitivity is 100% because that's your whole population. So yes, you will capture everyone, but preterm birth, you also capture a lot of people who didn't have preterm birth. The UDON index is over here, and you can see the UDON index, the highest UDON index we get is 0.5, and you can see that is at a cervical length of, if it's less than or equal to 14.5, which in practical terms means less than or equal to 15. And so if a cervical length is less than or equal to 15, our sensitivity is 79%, our specificity is about 70%, our UDON index is 0.5. So that's how you would say, like, okay, if I was gonna design a cutoff, I would use 15 based on this data for UDON. And then you'd have to go back into your data and actually use your numbers to calculate out what your false, what your positive predictive value and things like that would be. But that's how you use this area under the curve and how you would interpret it and how you would then apply that. So that would be, you know, again, that would be your cutoff. So you might say, based on, you know, this, patients with a cervical length less than 15 have a much higher risk for early preterm birth. So those are the people I want to study for further interventions. You can also, what was it? Also look at our risk score here. I feel like you can actually compare risk scores, but I think, I mean, compare the predictive value of multiple things, but I feel like I don't have the correct version of SPSS for this. But let me show you. So let's say we're looking at, like, okay, you know, we made the stress score including gestational age. So if you look at gestational age and cervical length versus just cervical length alone, does that change our predictive ability? And so you can see, like, the area under the curve with the risk score is 0.74, area under the curve with cervical length and gestational age included is 0.76. So, you know, just grossly, no. So you don't have, so although they are both significant contributors to, so although both gestational age and cervical length are significant contributors to preterm birth risk, your predictive ability isn't greatly improved by adding gestational age. It's very, so like the predictive ability is still most strongly driven really by that, what that cervical length is. And so you can, like I said, that you can do a p-value for comparison. I think I have an older SPSS version where I don't have it, but the newer versions you can. So you can actually get a statistical comparison for the predictive ability. And then also, you know, pictorially, you can see that these are basically the same. And as a comparison, we can also add, I'm sorry. So let's just look at, you know, let's say, so we looked at cervical length. Let's see if just how gestational age of diagnosis alone does. So gestational age of diagnosis by itself, not great. Area under the curve is 0.65. Although again, it's significant, right? It's statistically significant. P is 0.009. It is a predictor, but by itself, not very good, right? It's not really helping you much. Cervical length and the risk score are similar. Again, the risks, and you can see then the predictive ability, the risk score is really being driven by cervical length and not by gestational age of diagnosis. So those, you know, again, that's just a way of comparing your ability to predict something, or a screening test or a screening tool. You could use this for biomarkers, like you're measuring IL-6 and seeing if what levels of IL-6, you know, in cervicovaginal fluid predicts preterm birth or predicts infection, or, you know, A1C at the beginning of gestation, and how does that predict whatever response to anything. Hypothermia, all of the above. Why aren't we doing A1Cs? Any questions about that? Okay, I feel like that's good. It's 11:30. If there are, I feel like we've covered statistics wise, we've covered sort of the major things. We did, you know, categorical variables, continuous variables, ROC curves, survival curves. So if there's something else statistic wise you want to go over, let me know. Otherwise, our next lectures will be on sort of specifics of various types of study designs. Okay, thanks guys.
Thank you.
Oh, and then just to go back, so now that we finished that discussion, so what you were saying as far as screening out or screening in, that usually refers to positive or negative predictive value. So if something has a very high negative predictive value, it's good for screening people out. And so, for example, FFN has a very high negative predictive value. So if it's negative, that's really reassuring. But it's specificity is not great, right? So it could have it be but if it's positive, you have a lot of false positives. So it could be something, it could not be something. And then so the other way around. So what you were talking about is kind of like how a test does is whether you would use it to screen out or screen in. And so depending on how a test functions as far as sensitivity and specificity, you might use it for screening someone out or screening someone. Okay, thanks guys.
It was great, actually, follow from downstairs. So it helps you so much to know statistics. Again, it's not for everyone. Maybe we could say that as well, but just all the questions you have about anything you're studying, it helps to be able to. But once through an MFM fellowship is almost a must. I think. To know it, how you, even if you don't do research, how you can interpret the results, all the confounding stuff that goes, all the different statistics you can do, why they do them. It's so important.
Can you maybe do like another lecture, but using like maybe a journal to review things?
Yeah.
Because I
Like
think
an article.
I mean, I know like that's the point of journal club in a way, but more focusing on the methods, like methodology and like why those tests were chosen, and then kind of diving into like how to really, because I feel like sometimes that happens with like I look at the methods obviously, but then the analysis really but really to just like
actually, and I think you'll notice when you're reading articles, especially if you're reading like gray journal, pink journal, you'll see a lot of Mann-Whitney because most people are doing non-parametric. Yeah, because most of the outcomes we look at are not. Or Mantel-Cox regression. Right. So even for like clinical trials, where technically you don't need to adjust for things, but large clinical trials always do include adjust for site and some other potential baseline characteristics that could be not randomly distributed, even though they should be. And so those you'll see often the risk ratio is not a simple risk ratio, but like a Mantel-Cox adjusted risk ratio based on at the very least site, but often site plus a couple.
And you hopefully will do research, we'll read other articles in the future, but even if you didn't, we'll take the boards for sure. And this will come up. It's some of the favorite questions they have, like it or not, or just on this issue, see why and some tests. Great. Did we have blurb? The asthma blurb? Yeah.
I was just going to say one thing we can look at right now, just because it's come up recently, but if you want to, it was looking at like the S split and preeclampsia rather, but we can do that. Let's see. Yeah.
I'll stop sharing.
So I'll just share. Oh, I exited the Zoom, I think. Okay. Well, I just want to show you quickly because it does relate to the ROC curves. Okay, just gonna share quickly. So this is, just an example. So this is the New England Journal article looking at S-split for prediction of preeclampsia within 1 week of drawing it. So what here, they did a development cohort, meaning that they looked at S-split in a lot of people and they saw which ones developed preeclampsia. They did their ROC curve, they picked their cutoff. You can see this is their cutoff, 38. And they're like, okay, now let's see if we get a new cohort of people and we apply that cutoff of 38, how well does it do? So you can see your validation cohort is never going to have as good of a area under the curve as your development cohort, because of course you develop the score specifically in those specific patients. So it's always a little bit fitted to those specific patients, but you want to show that they're similar. So here you can see very similar, right? There's not that much of a difference. Yeah, exactly. So it's basically meaning like this is a valid in, not just this population we studied, but in other populations as well. And this is our, we're going to use that same cutoff because it's not like you can create a new cutoff every time you're doing, this test. You want to pick a cutoff that you can now use for future patients. And so that's, you can see, they've picked their cutoff, they applied it in their validation cohort, you're getting your similar results. So that's, this is an example of an ROC curve in real life. Here you can see they've just flipped the axis around. They started with in specificity, they just have specificity as %, but starting at 100 down here. So it looks the same as your ROC curve instead of doing 1 minus specificity and having your axis, go the normal direction, just small things so you can see that. So that's, that's an example of how you would, how you might see it in real life, if you will. Okay. Go ahead, Kavish. I think you were going to go through a blurb.
Yes.
Oh.
So this is just like a general asthma blurb for EPIC. And so I just categorize, I'll go through the entire thing, with the algorithm that I from the most recent journal article review on asthma. But this is the way that so far the word is. Okay, you can read it out loud or wait, just take a moment to take a look.
We go paragraph by paragraph, it's.
I know it's a little bit of a longer one.
Yeah.
But the first paragraph is really just an overview and what the risk factors of severe and poorly controlled asthma are associated with. And that's just the first paragraph.
Yeah.
In terms of the second paragraph, really it's just to include the patient's personal history. So whether they've been intubated, hospitalized for their asthma, their asthma triggers, and then specify the exact asthma medications that they're currently on or regimen. Then going on is just prevention, so mitigating, eliminating asthma triggers. And then finally, the next thing is just, we talk to patients about a peak flow meter, but I think giving them instructions on use is also important and exactly what that means. So I just wanted to have that specified so that we are talking to patients specifically about that. So it helps them monitor their own asthma symptoms. And then finally,
in that paragraph, in the asthma control, little paragraph,
yeah,
you're gonna put our most recent personal best
yeah, I can do that.
EF is XXX.
Yes. We actually don't have them in the office. We often borrow it, but I think that's something that we should maybe consider.
I sent like a YouTube video that explained how
It's like sent to the pharmacy for them to pick up.
It's sent to the pharmacy for them to pick up. Yeah. They used to have them at the hospital, and sometimes I would take them from the hospital, but I don't know.
And do you have the graphic in there below, or?
So the graphic is more for the medication
Yeah,
management.
yeah, that's what I mean.
Yeah.
You have the ACOG one.
This is from the Green Journal Review.
Oh, yeah, yeah.
Yeah, I just included the updates because the biggest thing in terms of medication management is now that we're doing inhaled corticosteroid containing regimens for both as needed and daily maintenance. And so that's the biggest.
Yeah.
update.
I had a question about that. So is there a problem with insurance coverage for?
There is for
Yeah. Because if you're taking something else, insurance, like that, I've had trouble just with dual agents. And so they'll say you're already taking, like, you know, you can't get another inhaler for as needed.
I feel like I've had difficulties with Pulmicort specifically,
Mhm.
and like that's what's recommended.
And that's what's recommended, exactly.
And so sometimes what I've been doing is just Symbicort, which is just budesonide,
Okay.
and then unfortunately doing still the albuterol, which
Mhm.
is still a SABA, I guess, but
Mhm.
it's still frustrating because that's not really the recommended.
I know, that's
Insurance, especially for Keystone First as well.
what I was wondering, like you can't, or if you even get Pulmicort covered, you have to, and they're taking like 1 puff twice a day, but then they take, 8 puffs because they're using it as needed. Now they've run out of their Pulmicort, you know what I mean?
Right. So I haven't been able to figure out a good workaround. We should contact someone from pulmonology
Yeah.
and see if there's any recommendations they have for, because I'm sure they're prescribing these medications. I mean,
Right.
this is coming also from their societies too.
I remember there was like a dot phrase that like a generalist at sent out being like, include this in your note because they will use that to like then justify like coverage of Pulmicort. Like if there has to be a specific statement that says.
Yeah, exactly.
Need is
correct.
Yeah, so it has words. Yeah, so we have to like include a certain dot phrase. I unfortunately don't have that dot phrase anymore, but
If
I
you know
assume-
someone who's still there that can
Yeah.
get it just in the note or when you order the prescription.
In the note, in the
That would
physician
actually be
note.
helpful
Yeah.
because then I can just put it directly into this
Yeah.
blurb
Mhm.
and then we have that. And then I just included a line on no increased risks of fetal abnormalities given the situation going on with the world.
Yeah.
And then information about asthma exacerbations and then antenatal management in the setting of more severe asthma. Below is just the algorithm that's directly from the Green Journal article about the summary of asthma. And I think it's just a good way for us to also take a look and see like, okay, based on their symptoms, what should we be prescribing? Because I think that's often something that we have questions on.
Oh, you know what I was thinking? Because since we're doing this, like if you put this in PowerPoint, if next to it, you can write out the actual drug name.
I
mean, just so so people know what to order. They're not like looking up, which one has what has.
The brand name.
I'll just write like, say like IE Pulmicort
I can do that. Just so that we know what exactly.
Yeah, so it's like easy for them to just type it into Epic and order it.
And then I can probably honestly just put, because it's saying like, what is low dose, what is medium dose? I can probably just put.
But the dose, exactly, yeah.
That'd be great.
And then also what I like about this is when to refer to pulmonology, because that always becomes a
Yeah.
question. So I think that's a really nice algorithm based on their symptoms.
Yeah.
Yeah, remember there were grand rounds on this, and that's exactly kind of what they say as well, which is perfect.
So I just try to
Makes it a little
summarize.
easier now.
Yeah.
Sounds good. Any other ideas? Or I
So
don't
we'll
know.
get the dot phrase from Eileen to add on so that insurance can cover for.
It might be more complicated than that, but
It'll be helpful.
yeah.
At least it's a good starting point.
Flow, yeah.
And then maybe I'll reach out to pulmonology to see what they do about it in the
Yeah.
meantime. And then I'll edit the algorithm.
The serious estimated fetal weights. Thank you so much, Kavisha, for like touching on this
I'm
topic.
on Advair and I couldn't get a Symbicort. So I had to just get, so I had to just get a albuterol as needed because like my insurance wouldn't cover me to take Advair and Symphor. Yeah, that's what I was wondering, because it's two of the same class. It's like two medicines in the same class, so it won't cover that extra inhaler. Since I just still have an albuterol inhaler.
Can I ask a question? So for the fetal weight, I'm very much happy that we touched on that. And are we gonna classify who's gonna be getting all our asthmatic patients? Like, did we?
I put it for severe specifically, like poorly controlled asthma, like patients that are even on the new immunologics that are there.
Maybe you can define it like 2+ medication or greater than 2 medication, maybe something like that.
Yeah, but for me here, we also, I would love for us, not necessarily today, but many times you'll have this patient who does not have any indication for a fetal weight, and she has some mild asthma just on an inhaler. So I hope we can look at that to see if, like, mild to moderate asthma, is that an indication to bring somebody for a fetal weight, basically?
My understanding from that review article that it was mostly associated with severe, not so much the mild to moderate categories, but mostly with severe. I'll clarify exactly how they define severe, because then that could be.
Thank you, Kavisha. This is a very comprehensive. It's not even a blurb; it's like a guideline or something. But this is Kavisha's work. This is great, fellows. You guys are amazing with your work.
And also have it under. Switch it.
Okay, thank you very much.
So I think at noon we have Carrie's surprise. I'm sure people will come here soon.
Is it in this room? It's on the 8th floor.
It's on the 8th floor.
Back
Okay,
in work
perfect.
room.
Announcement. Okay.
No, I just checked. I checked it.
Make sure that we're ready for that. Do we want to touch? We have about 20 minutes. Do we want to touch on focal length cutoffs and what to do and what to do based on the experiment? That's kind of what the last item I think we have, unless there is something else. I'll try to shut up as much as I can. This really should be a discussion and, next step forward. It's interesting, the one thing I want to bring up, that 3 patients came up in the last 2 hours, so even just for patients, clarity, to be all on the same page, what are we going to do? Like, Uda even had somebody from, what was the patient from with 15 millimeters?
I know, no, 13. And now I can't even sign her report. Like,
I'm downstairs, you guys.
Yeah. So I'm torn apart. I'm like, okay, I should know your paper at less than 20.
Right.
Yeah.
So the question is, right now we use, less than 11, to recommend cerclage based on SMFM, ACO, etc.
And we did do a speculum and digital exam on this patient, but she was history of no. Yeah, singleton, pregnancy, no lip, or fine rather, but no prior history.
Yeah,
but she was 13.5.
Okay.
So, and she wasn't dilated.
So, I'm still torn because the data, if you look at this is what I was just trying to pull up, what we're looking at really is additive benefit of cerclage. That's what the real question is. For patients with on vaginal progesterone with a cervical length less than 10, they remain at very high risk of preterm birth, even with vaginal progesterone. Like if you looked at the Romero meta-analysis, like the risk reduction with cervical length, cervical length 20-25 is here, 10 to 20 is here, and then it's like 1 basically. If your cervical length is less than 10, vaginal progesterone is not really doing anything the shorter your cervix is. So I think there is benefit, and I think it's a matter of deciding what that cutoff is. Does it have to be as low as 10? Maybe not. Is it as high as 20? I don't know. So I think that's sort of where I'm stuck. The retrospective data that looked at cerclage on top of vaginal progesterone those were not patients with a cervical length of 21 to 25 or even 15 to 20. It was either under 15 or under 10. And it's retrospective. So it's like maybe they were having further shortening. And so should we do it based on further shortening rather, versus stable? So your cervical length is 17 and the next time you come back, it's 18 or 19 or, and then versus it's 20 and then it's 16 and then it's 13, those are two different trajectories. And so I think that's what makes it difficult to interpret retrospective data like that when it's based on potentially actually serial cervical length monitoring and a progression of cervical length rather than just a one-time assessment, which is what we would be applying it. I think that the data supports the benefit of cerclage. So I actually think it's fine to offer it. So if someone's coming in asking for a cerclage, you can go through the risks and benefits, including increased risk of C-section, right? That's been associated with cerclage. And you can counsel them individually on what their benefit may or may not be. And you can say it's unclear what the added benefit of a cerclage is at a cervical length of 19. Whereas I think it's quite clear at a cervical length less than 10, there is added benefit to a cerclage with retrospective and prospective work. So if someone talked, it's like an outside MFM who refers patients for cerclage to us, says, I talked to this patient, her cervical length went from 19 to 13. I think she needs cerclage. Like, that seems reasonable to me. Which is different from telling everyone at diagnosis of a cervical length of 20 that they should have a cerclage. I don't think we have data to say that you should have a cerclage in addition to progesterone based on a one-time cervical length of 20. So I think that's sort of where I'm at. So I think we could develop something related to either progressive shortening or cervical length less than 15, just based on, our data. But I wouldn't recommend to everyone with a cervical length of 20 that they should have a cerclage.
Yesterday, essentially, she was closing, prescribed vaginal progesterone.
So the case from yesterday was actually serial cervical length. She was noted to have a short cervix of 21 millimeters. Then came back a week and a half later, was 14, then came back again and was 13.
But honestly, we did not offer her a cerclage, correct? We offered her latch, and that's why I'm torn apart on it.
Like the Encapine study was cervical length less than 10.
Yeah.
Cerclage was beneficial with patients in a cervical length that were to less than 10.
So the question is here, do we have to call her back also, like to offer her the cerclage? And then she...
Well, let's finish the conversation.
What did you say?
Let's finish the conversation. So it sounds like, Huda, you're more for it. I don't know. Amanda, are you listening? Any
Yeah.
You or Whitney? I don't know. No, Whitney's not on. And we can certainly, Moti is not here. Anybody around the table? Any fellow comments? One thing, I've been thinking about this, and it takes time to absorb, and so I'm all for continuing discussions. In fact, we probably won't decide anything today. We probably have to look at the guideline itself, represent it here, and especially follow Rupsh's advises, finagle the wording in terms of considering and the changes and stuff. But one thing, I went back and look at your trial, which is the only data we have. I know it's 90 patients, but it's our patients. And I was pleasantly happy when I saw, that your primary outcome was preterm birth less than 35 weeks. The relative risk was 0.70. And the confidence interval, I think, went to 1.06. So it seems like even if you have progesterone on, and your patients did, it works about the same. But there was no significance, and we would need to. So there was another, because the retrospective data, I agree. There's so many confounding variables, so that's what we. Any other comments?
Oh, well, we love the debates here, correct?
Yeah, that's what it's all about.
It's all about debates and learning, and yeah, so this is great. Thank you.
Any other comments? I feel bad again that maybe if we'll discuss it some more among attendings,
Yeah.
even by text and stuff. I'll
I think like
let's see what
the
the Monday.
clinical scenario that's always concerning in terms of patients where I
Yeah.
want, like, is the patient like that we just described, which is that serial progressive shortening that doesn't yet meet technical criteria.
Right, and then you're like, just come every day until it goes on. Right, then that's what I mean, like for like that patient, I think sure, like, do I need to keep seeing her every 3 days until it falls? No, it's progressively short.
I do think it's more difficult to.
There are definitely the people who have a cervical length of 17, they start progesterone, they come back, and then it goes to like 24, and then.
And a cerclage isn't a minor
It's
procedure.
not, we've had complications, there is a difference in C-section rate. It is a small population, right, like 1 to 2% have a short cervix, and not a lot of patients that we're talking about.
I wonder if you could.
But I'm a lot more cautious with a cerclage recommendation than vaginal progesterone or aspirin, right, when we're talking about our sensitivity, right?
I'm just wondering if there was like, if I saw somebody shortening, say over like 3 measurements, but all 3 still above 1, like that would be somebody that I would be like, that I would like want to have a cerclage or like feel like I was heading in that direction. Even if it was, I don't know if anyone would shorten so minimally that it would remain above 15 in that time, but 1 between 2 and I don't think they do.
Universal.
I think at the
20 is
yeah, I think at the very least, I think most realistically, what it makes sense to do is do serial screening, and then you can consider for less than 15, and recommend it for under 10. I think.
Yeah.
And then the consider, allows the patient to say, look, do I need this surgery? I really don't want a surgery. You say, okay, well, let's just keep an eye on it. If it falls less than 10, then yes, you definitely should get it. And versus the patients who we all see who are like, this is already shortened. They get very anxious because it already shortened and they don't want to.
I think I would have to see more, I would want more data for a universal one-time screening less than 20 before recommending it.
Even for colors, our enrollment was, I didn't actually look at the numbers, but people often didn't enroll right away. However, people whose next cervical length was shorter, we're like, oh, I'm not sure. Can we just follow up my cervical length? Great. Follow up the cervical length shortened, and then it'd be like, oh, let me do the trial.
Yeah, I mean, it's hard, I think so it's 507 patients, right? In the meta analysis included the 90 from. I think a lot of them were first measurements, but not all. And some probably didn't even record it in like, even when I did my study a while ago, I think a lot of them were the first time, but some waited, go shorter, and then they got randomized.
Yeah.
Another piece of the puzzle here is, what's the natural history of somebody with no prior burn birth, 19 millimeter cervix, how many of those shorten to less than 15, less than. What the issue is, you don't want to wait too long, but you also don't want to cerclage the ones who are going to be the same. We'll look at some of this data in the literature you could see from the vaginal progesterone.
In the trials, they didn't continue cervical length monitoring after randomization, right? Like the progesterone trials, that's the problem.
Yeah.
That's what we don't have, is like looking at the natural course of cervical change after progesterone therapy.
And another thing for the future is I really don't think that in this kind of patients, if your cervix is 21 or more, 20 weeks or after, that cerclage is beneficial. You know, we looked at the subgroup analysis, and those services are probably not going to short anymore. Again, this is somebody without a paraspecific burden, only carrying one baby. You know, a 22 millimeter cervical length is probably pretty good, and they're going to do well. We already decided to give them vaginal progesterone, you know, at EASWOG. So I gave this procedure, EASWOG. And Andrade, you know, is kind of a famous OBGYN. We've been everywhere now in Houston. Saying, if you remember, Romero's meta-analysis between 21 and 25 did not show benefit. You know, the guidelines.
Yeah, the relative risk was similar, but it crossed one.
Same story. Exact same story with your cerclage data. So he was like, well, maybe we shouldn't even give progesterone between 21 and 25. I said, hold on, let's not make it more confusing than it is. But clearly, the longer the cervix, the better people are going to do even without anything. But Rupcha's point, remember well, assuming progesterone works, it works for the longer cervical lengths. So it does make sense at 10 or more. You know, you want the more progesterone, you want to continue the progesterone throughout the pregnancy. And hopefully that's when the ones that it will be most beneficial for.
What about someone that shortens to 15 to 20 while on progesterone?
Yeah.
I think about 20. Yeah, or like 16, but they're on progesterone. Would you still offer them? Wait for them to get them.
Is this the second
Yeah,
one,
this is,
2022?
yeah, so here, this is,
People
so
bring it up.
21 to 25 and 10 to 20.
It's about the same.
Yeah, the relative risk is the same. It crosses one, but your numbers are so small that of course it's gonna cross one.
Yeah.
The difference here is not that it crosses one, but it's that the relative risk isn't even trending in that direction. It's 0.97, meaning like there's literally like no impact.
Yeah.
Right, so that's 105. Over here, this is N of 105, this is N of 128, relative risk is 0.55, short crosses one, but it's in line, right? Like this is in line, so you could say like, okay, probably that's a power issue. This is not a power issue. Right, like this is just, I mean, it couldn't be more
It's essentially
not significant. So that's what I mean. So for me, like cerclage works. Vaginal progesterone does not seem to work. Because for cervical less than 10, I really don't have any qualms about recommending a cerclage. But
You want to bring up your randomized trial real quick and
let's see where.
And you know, so I think using vaginal progesterone for a cervical length of 22 millimeters based on this.
So it wasn't published. The fact was stronger. The risk reduction was stronger in the Italian.
Yeah, that's true. We used the same 200 milligrams as far as we know.
Yeah. They had more Sherrod cuts, I think.
Yeah.
Right. I think it was more common. Yeah. So this is the survival curve. So again, just the trend is
not showing.
Oh, it's not sharing. There we go. Survival curve. Oh, gestation, it's similar. It's gestational age at delivery versus latency from randomization to delivery, but same idea. So blue is cerclage with progesterone, red is progesterone alone.
I mean, these were actually positives. You know, they were statistically significantly better, right? Both of these curves, which you can make the case then all the way to 25 millimeters. So
yeah, for gestational. And then I think I did subgroup ones. Oh, this was rate of preterm birth by cervical length.
You see, that's why, and again, I'll be the devil's advocate. That's why this is data, the blue one, you know, they got progesterone, right? So
yeah.
The red one, I'm sorry.
Yeah, you're right.
Only progesterone.
Oh, but red is only progesterone.
Cerclage and progesterone, as you can see, and all the way to 20. I mean, that's that's pretty impressive in terms of a benefit. If you go to your table of primary outcomes,
I thought I had another one, maybe not.
the previous one, maybe table 2. What, the primary outcome was 35 weeks, and here's what I've been talking about. This relative risk of 0.70 actually goes all the way to 1.63, but it was 23% in the controls, progesterone only, and 16% with cerclage, showing that the effect is the same, if you're not on progesterone or if you're on progesterone. I think, to me, that's what he says. Well, let's I'll bring up I'll find a little slot. I'll bring up the actual guideline and we'll edit it. Very good. Free lunch upstairs. Yeah. Good morning.
Talking about, sorry. Okay, yeah.
We're gonna go there. You for resting. Sounds good. You guys, I think Sam's already there.
Yeah, he texted us.
Yeah.
So we can go upstairs, but I think it's nothing super urgent. They've been running my.
Really? She's running a tight ship. She's making sure you're working hard.
And all day long, night, day, 5 o'clock.
Dr. Bergella.
It's a client, I mean, she's relentless.
What do you ask? My opinion about what?
If these are, do you think these primary are like strong enough, or should there be another thing that we should consider?
Was there something, I mean, it's hard for me to say without like sitting down to actually read through it. I would say the main thing that's missing would be a 5-minute app cover, because that's sort of more sensitive than nicotine, which vary for a lot of different reasons. Yeah, but you do have morbidity related to sort of like the nuclear intervention, so that's fine. I mean, I guess what is missing? Like I think things like shoulder dystocia, postpartum hemorrhage, that's not relevant, like, so unless there's something that's missing.
No, I just wanted like your opinion on if you think these are good, and then probably like APGARs, we can try to go back and find that for like
just publish your results. Of course, excited to see that.